definitely, sir. Yes.
Actually, the whole principle of epilepsy surgery is to find the focality on any epilepsy.
Sir.
If there is a focus, differentiating between generalized seizure and a focal. If it is a focus, most likely it is susceptible. It depends on your determination, the location, and many more factors. I had one question. Did we study this high frequency spikes?
Sorry, sir.
High frequency spikes seen around
None, sir.
high frequency oscillations that are seen,
Uh,
HFOs that
no,
are
sir.
seen.
No, sir.
It can be studied even with the other. So not only issue is you need a better amplifier. You better amplifier.
We use the
That
Nicolette system.
I have a suggestion actually.
Yes, sir.
If we include that, currently this has reached a dead end. Chasing the irritable zone has reached a dead end. And the irritable zone in some lesions which are on the right side, maybe on the opposite side. You have the ultimate example of a hemispherotomy patient who have all forms of activities on the opposite side. But this is a good region to probe into. And my suggestion is we should study these high frequency oscillations, which have a much greater correlation with the epileptogenic zone. Of all types of zones which can be marked, it is HFOs which are likely to give you. It has been done, but whether for leads where it has been done is a question.
The problem is that the sampling rate and the occurrence in a brain acute intraocular is difficult.
Yeah, the
compared to
issue
the
with
technical-
issue with HFOs is HFOs cannot be studied with your typical surface this one. You require a very elaborate set of small tests going all around, which is not going to be that easy,
Plus,
particularly for the
whether
leads.
anesthesia also can have a say in.
Anesthesia may not have. These ones may not have. These are independent.
Right.
In fact, they have a deepest correlation with this one, and is a way ahead. Now, I just had a comment actually. When it comes to a lesion, one of the most important factors is how long it has been evolving. If it is the lesion is new and the seizures are new, the whole idea about finding the irritable zone around may not carry much. Like you have the extreme examples of our gliomas or a glioblastoma, present in the seizure, but you cannot really go and remove anything around it. A lesion like a cavernoma, which has been there since childhood, there's a meaning in doing this. And but unfortunately, it is the seizure that matters, and a prolonged recording may be the real answer.
Yes, sir. In our studies, we found that in both the pediatric and adult age patients, the mean duration of epilepsy in these patients were around 10 years. So, whatever.
In children means children is a variable category. Up to 18 years a big wide category. Now there is also a negative correlation. Those people who chase the spikes get a poorer outcome in many centers. It has been one reason why this has not become popular. It's difficult to take a randomized trial in this.
So, question to Matthew as an extension. So, do you feel that the irritative zone keeps on increasing with time, or what's the reason between that duration?
Although modern epilepsy surgery does not accept the principle of a kindling as a one, practically, if you see those patients who have a long-standing lesion have a much wider, when you do it directly, a much larger irritable zone. And we all know that the evolution of epilepsy does not take place overnight. For if you take an MTS is both a network as well as an epileptogenic. There is an overlap between the two. It takes 10 years before at least a decade before the pattern evolves. So likely that the irritative zone may be expanding.
Thank you.
Thank you for those valuable comments.
Small question.
Yes, sir.
Nice presentation. I'm not getting into the nitty-gritties of the study. I don't have. I think time is not there.
Sir.
After the study, have you stopped doing ECG?
In our institute, we still
Have you
do
stopped doing ECG
No, sir.
for these
Basically,
lesions in institute?
So what
No,
we
not
try
for
to
every-
what we try to say is that nowadays it's more institutionalized when we are doing epilepsy surgeries, and I think what we tried to find out at the end of it was that even centers where you don't have specialist epilepsy equipments, like if you don't have electrocardiography also in lesions like leads, it is not warranted that we need to have electrocardiography, because the burden of these patients on an institution will increase if it becomes a referral center for all these cases. So by reducing that, sir, it's not just about the machine, no, sir, because we need an epileptologist, technicians. May not be feasible in all institutes.
Yeah, first of all,
Sir.
congratulations for your study
Thank you, sir.
and also for the publication.
Thank you, sir.
Often, negative studies are not published. So in that way, I think it's a good thing that you published it. Now, multiple factors will influence. For example, ganglioglioma,
Yes, sir.
apart from what you see on the MRI, small nodules of ganglioglioma can be scattered in the neighborhood, which you won't find on the MRI. Everyone knows that DNETs can associate with dysplasia,
Sir.
which may be very obvious or may not be obvious. So corticography has got some role, but you should take corticography as a learning experience. For example, in these cases, in temporal resection, it may not have much value. But in malformations, it's very crucial, especially for those which are having intrinsic epileptogenicity. Only when you learn, it has got a lot of artifacts and a lot of limitations. Only when you learn all the intricacies, when situation arises where you need crucial information from corticography, you'll be able to derive it. So you please continue your interest, don't stop, and all centers which have the infrastructure technology should continue to use it, and I'm sure new information will evolve.
Thank you, sir. Thank you so much.
Congratulations.
Thank you, sir.
In your study, have you differentiated between, when you do corticography, between oligospikers and heavy spikers? Some
No,
tumors
sir.
you may not just get any spikes or very few spikes. So
No, sir.
corticography won't add to the completeness of resection. Whereas in heavy spikers, we have seen, especially as Bhaskar mentioned, focal cortical dysplasia surrounding a ganglioglioma or a DNET, you do get some heavy spikers. So have you differentiated between the two categories?
No, sir, we haven't really assessed about the differences in outcomes in these patients, basically.
Any comment, Matthew, regarding that versus oligospiker?
Absolutely correct, actually. Sir has pointed out a very important thing. You will find a small set of patients who have very brisk spiking, where it is very difficult to leave that territory there. And you won't know. It is very difficult to create evidence on that, but once in a while you will find this category.
Yeah, thank you. Yeah, thank you for a
Thank you, sir.
nice discussion and a nice presentation. With this,
Next
this session is over.
Next, request of chairpersons to give a token of appreciation to our speakers. I request Dr. Anand sir. Anand Bindu sir. Next, Srinath sir. Next, I request Dr. Suresh Nair sir to give token of appreciation to our chairpersons.
Save some time because I am sitting in the front. Only one for everybody.
No sir.
One is sitting. That's the today like a nice. Okay.
Thank you so much, sir. We shall now move on to the epilepsy session, where we will explore the latest advancements and challenges in the field. We are honored to have Dr. Matthew Abraham, sir, Head of Neurosurgery, Lisi Hospital, Cochin, to chair this session. Dr. Bhaskar Surya Narayan, sir, Professor Neurosurgery, AIMS, Jodhpur, and Dr. Sunil Kumar, sir, from Trivandrum Medical College. We invite them to moderate this session. Please join me in welcoming to the stage. Now I would like to call upon Dr. Malla Bhaskara Rao, sir, Professor, Department of Neurosurgery, NIMHANS, a renowned expert in the field, to deliver his enlightening talk on opportunities and challenges in epilepsy surgery. His vast experience and insightful perspectives will undoubtedly provide a comprehensive understanding of this complex topic.
Bhaskar Rao sir does not really need any introduction in this field, at least. Most of us have learned the basic techniques of our foundations of epilepsy surgery from him. Over to you, sir.
Thank you. Good afternoon to all of you. I will touch upon a few challenges and opportunities which I faced during my 30-year career, but this presentation is largely autobiographical, so please bear with me. From professional point of view, I'm very fortunate. Best thing which happened to me is get trained by Professor Ramamurthy, and then the next best thing which happened to me is joining Sri Chitra Tirunal Institute. I'm grateful to Professor Valiyathan, Professor Raut, Professor Sambasivan, Professor Ramamurthy, Professor B.K. Mishra, Professor Suresh Nair for all the support extended during my initial career at Sri Chitra. I started doing spine surgery, became a very accomplished spine surgeon. Most of my work was cervical spine surgery. But in 1980s, a lot of things were happening in the field of epilepsy. NASA has done research on chimpanzees, especially monitoring chimpanzees' heart and brain in space, and with UCLA collaboration, that became available for civilian purpose. And you know the contribution of imaging in the field of epilepsy, and of course people started understanding this difficult or drug-resistant epilepsy syndromes which can be surgically remedied. So with that developments worldwide, the ideas were floated in early 90s at Sri Chitra, Dr. Bindu Desai and Dr. Sanjeev Thomas, and of course subsequently by both Dr. Radhakrishnan and Dr. Raut. This is Dr. Mohandas inaugurating the epilepsy surgery program. The first patient I operated, as soon as shifted from OT to the ICU, started having seizures. So Dr. Mohandas, director, called me and asked me, are you operating to cure epilepsy or cause epilepsy? So later, few months later, I went to Mayo and MNI, and I asked the same thing, that what is the incidence, prevalence and consequences of acute postoperative seizures. And I was told that there was no study published, and then Mayo gave me access to go through all the records, and then with that I could able to find that nearly 18% of people after anterior temporal resection can have acute postoperative seizures, and then this was published in the Journal of Neurosurgery. So already there were, I think, approximately some 9,000 people with epilepsy were registered at Sri Chitra those days, and then a lot of referrals used to come. Not only people with uncontrolled epilepsy, but when the news spread that Chitra started epilepsy surgery program, even a lot of people with cerebral palsy, a lot of people, children with ADHD, they were all referred with occasional seizures, were referred for surgery. Of course, we took great care initially in selecting the ideal patients. For example, this young girl had a temporal DNET, operated some 25 years ago. Now she is vice president of a multinational company. We very early in this program, we realized the curative power of epilepsy surgery. Every occasion is celebrated. This is after completion of our 100 epilepsy surgeries. It's a great teamwork. In this growth, again, I'm very fortunate. So many people guided us, helped us. This is Professor Jacob Chandi with many senior neurosurgeons. Professor Kaku passed away recently, and Madam Gauri Devi, Dr. Raut. This is Professor Ramamurthy and Dr. Balaparameshwar Rao, Dr. K.S. Mani. They were all very supportive of our program. This is again Dr. Mani, Dr. Radhakrishnan, Dr. Satish Chandra, and Dr. Ashekar Nair. And this is Professor K.V. Matai and Dr. Sambasivan. And again during the NSI meeting at Thiruvananthapuram. And it's not just professional, there is a great support. This is Professor Raut with my daughter. After Professor Raut and Dr. B.K. Mishra moved out of Chitra, we had leadership by Professor Bhattacharya and Dr. Professor Suresh Nair. So I'll just few pictures I could able to find, and then I'll just show you how the mood, the ambience, the atmosphere in the department. This is Graham Teasdale visited Thiruvananthapuram, and you see the jovial, happy occasion of so many people, not only work related, even personally at home. You see Professor Bhattacharya with Girish and all family members, and Dr. Bhattacharya carrying my daughter. So I take this opportunity to join all others to wish long life, happiness, good health to Dr. Bhattacharya, and we are all grateful to you, sir, for what you have done. Of course, the program slowly started gaining popularity in India, as well as the Chitra epilepsy program started getting worldwide recognition. This is Professor Pete Engel and Herbert Sylvanus, and they not just some sort of guidance regarding how to choose patients, but they became very greatly supportive throughout our careers. This one. Anyone can recognize this gentleman in the photograph?
One person I can recognize.
This is Theodore Rasmussen. I had an opportunity to spend some time with him at Montreal, Tetsuo Kano. And then this is like probably a proverbial rubbing the shoulders with giants, with Osama, Al-Mufti, and then all the Kawase, Japanese, the giant neurosurgeons. I got award from the International League Against Epilepsy, and the paper was published in Epilepsia, which became like popular and became like a model for the developing world. And then not only stopped growing the program at CHITRA, but also like-minded people went all over the country and then supported young neurologists and neurosurgeons in developing their own programs. So what started as one case in 95, now more than 12,000 epilepsy surgeries were performed all over the country during the past 25 years across more than 60 centers. Then after establishing the temporal lobe surgery, we started getting difficult cases. So we wanted to get additional expertise. So Dr. Radhakrishnan went to Mayo Clinic. Then I went to Austin and Repatriation Medical Center at Melbourne, and then I went to King's College Hospital at London. At the same time, during our absence, we wanted the program to continue and grow. So Ravi, Girish, Joseph, Sailaja, all of them were trained, and then they carried the program during our absence. So when we learned about cortical epilepsy, extratemporal epilepsy, like for example this focal cortical dysplasia, we came and again started with great enthusiasm. Those days there was no navigation. This is using the surface landmarks. You see, there is a very prominent cortical atrophy, so that identified, and then the lesion was resected. We also started extratemporal resections, and then started implanting. This is a young boy who came from Kashmir. Small area at the occipital pole was identified as the Scheser onset zone, and that was resected. And surprisingly, he had no field effect. So suggesting that the insult started very early in the childhood with a lot of plasticity and reorganization. Of course, subsequently became a successful businessman as well as a family person. Not only in Chitra, I had an opportunity to initiate epilepsy surgery in Sri Lanka also. So actually there was a great opportunity. Hundreds and thousands of soldiers sustained head injuries, and many of them developed post-traumatic epilepsy. So there was a request from government of Sri Lanka to move to Colombo and then start surgery for all those soldiers. But probably fate or destiny took me in a different direction. I went to two defense establishments in the Middle East. I never met Professor Chopra or General Khalaf in my life before, but both guided me to move to those places, and then I continued my epilepsy surgery work. Even in those days in the Middle East, I invested my time, my energy, my financial resources to continuously update myself for training, for research. This is at the Venice International University. You see, that is Gregor Wieser. Along with me, you can find Sarachandra also in the picture. So we were all brainstorming how to improve epilepsy surgery programs in countries with limited resources. Of course, I continued my association collaboration with all the thought leaders in the field of epilepsy. Then I returned to Mumbai, and here again good quality epilepsy work was done. For example, this case illustrates that epilepsy is actually progressive disorder. This boy had a frontal lobe epilepsy, and imaging showed malformation in the frontal lobe. And then for fear of surgery, the family continued medication. They came to many places. They came to Sri Chitra, then they went to London, they went to Cleveland Clinic, and then by that time he developed temporal lobe epilepsy. Initially started with the frontal lobe epilepsy, which subsequently became temporal lobe epilepsy. And also boy became lot of behavioral problems because of the progressive nature of the epilepsy. You see, there is a frontal developmental like a polymicrogyria, and then there is a secondary hippocampal sclerosis. So because of the worsening of his condition and both being adjacent, both being non-dominant, we with a consent family discussion, both were resected, and this is almost like nearly 20 years, and then after that he never had seizures. This one, this the boy. And then when I moved out of Chitra, I felt like paradise lost, and when I joined Nimmans, it's like paradise regained for me. This is there is a great leadership at Nimmans. This is 4 directors of Nimmans, and this is with Professor Das, who passed away, and we have an army of consultants and residents. In spite of doing 1000 epilepsy surgeries, still I find sometimes cases very challenging. This is a case of right hippocampal sclerosis. I started doing routine temporal lobectomy, which I have been doing for the last quarter of a century. So just see the field. This is the right side, plan anterior temporal resection. Look behind here. There is a spontaneous subarachnoid hemorrhage unrelated to the dissection technique, away from dissection technique. Spontaneous subarachnoid hemorrhage recorded. Within a matter of few seconds to minutes, brain became so tense. In fact, I had to stop my epilepsy surgery and then cut the dura to release the pressure and all those things. I thought probably during surgery patient had some aneurysmal rupture and spontaneous subarachnoid hemorrhage. Of course, subsequently we have investigated. There is evidence of subarachnoid hemorrhage, but angiogram did not show, and extensive workup even by the hematology group did not reveal any cause for subarachnoid hemorrhage. Of course, he had a history of drug addiction and then some sort of deranged liver enzymes. Anyway, with technology and excellent infrastructure, we could able to take care of many difficult patients and cases at Nimmans. Not only service, for example, Matthew was talking about high frequency oscillations. After the invention of EEG more than a century ago, the next progress is detection of high frequency oscillations. Now at Nimmans, with magnetoencephalography, it became possible to identify these areas of high frequency oscillations. Eventually these things will lead to non-resective surgeries. You can create a thermal lesion either with a laser probe or a RF lesion, and then cure or control epilepsy. not only preoperative, even intraoperatively, this is in collaboration with Indian Institute of Science. Indian Institute of Science have got major research projects on normal cognition, on vision, on hearing, and they wanted to identify the gamma oscillations with acoustic and visual stimuli. Their idea is to identify people with Alzheimer's and dementia very early in the course of the disease. So this is during epilepsy surgery, the people from Indian Institute of Science come to NIMHANS, and then with acoustic stimuli, they are able to elicit gamma oscillations in the Heschel's gyrus, identifying which type of acoustic stimuli will produce the best response. Not only intraop response, even postoperatively, this resected specimen is like a gold mine, and we have done some work on the impact of integrated medicine on the hippocampal neurogenesis. Of course, our neurogenesis is a very difficult area to do research. We are not hugely successful, but some trends were observed. Of course, what I have done, what CHITRA has done, what all other institutions are doing will become outdated soon. I mean, technology is growing so fast, and we have to keep ourselves up to date. So there are global challenges are there to initiate epilepsy programs, to expand and improve the programs, and also to do a lot of basic research. So finally, I'll leave my wish list for CHITRA, which the current faculty may consider. So CHITRA has played a pioneering role in epilepsy surgery. Now, if you look at the websites of the National Hospital at Queen Square or Montreal Neurological Institute at MNI Montreal, they repurposed themselves to changing trends, changing times. So their research, current research, is completely different than their pioneering roles. Maybe CHITRA has to repurpose this one. Now, All India Institute has got Center of Excellence, and they are able to do enormous amount of work. They have publication in New England Journal of Medicine, randomized control trials, and then extensive research. NIMHANS has got fabulous technology. We have intraop MRI, we have magnetoencephalography, we have gamma knife, we have PET MRI, and even AIMS. Ashok is here. AIMS has excelled in implanting stereo-EZ in a large number of people. So CHITRA has to repurpose and then focus heavily on mentorship. For example, so many neurosurgery, neurology alumni are there. Why can't CHITRA go and help them to set up their own epilepsy surgery programs all over the country, and even huge referral basis, their referring physician, they can have a lot of collaboration. And in fact, CHITRA can develop epilepsy surgery programs not only in India, but many other low and middle income countries, including in Africa. And you know, the hippocampal resection, which we have been doing all this time. Now there are papers have come up where hippocampus is removed through nose and through orbit using endoscope. Excellent endoscopy work is happening in CHITRA. Why can't faculty collaborate and then use the endoscopic expertise to the epilepsy surgery? And CHITRA is very uniquely positioned because of the biomedical technology. So many devices are coming. Seizure detection device. Like if a person comes to know that 10 minutes later he is going to get a seizure, he will stop driving, swimming, he will take rest, he will go to hospital. All those devices, so much of work is happening where BMT can potentially contribute. And of course, tissue repository, it's a gold mine. Don't throw. When you do epilepsy surgery, if you have facilities, use the tissue for research. If you have no facilities, store it, preserve it. if you, otherwise you can send it to centers which have got facility, but don't throw it. It's a gold mine. So finally, I want to thank the organizing committee for giving me an opportunity to meet and then share some of my ideas with you. Thank you very much.
Thank you, Bhaskar Rao sir, for such a wonderful talk. Opened a wide spectrum of thought before us. It's open for questions and comments.
Very thought-provoking talk, Bhaskar. In the recent World Neurosurgery Summit in Delhi, there were Taiwanese and Japanese neurosurgeons who presented transnasal and transorbital resection of hippocampus. But they did it only limited to tumors, where it's only an anatomical resection. And their papers have come under severe criticism from epilepsy surgeons and epilepsy centers per se, that is not a simple anatomical resection. So since you mentioned that, what do you think about it?
Paul Gardner is now doing an in hippocampal sclerosis, and he has published also. He is presenting worldwide, from Paul Gardner from Pittsburgh. I think this is like combining expertise from multiple fields. See, when I was working in CHITRA, I met Dr. Bayar Yadav from Jabalpur. I told him that I don't know how to do endoscopy, but please teach me. I want to use it for epilepsy. So ideas were there, but unfortunately that collaboration didn't happen. And now, you know, Sarath has done such excellent work. Now, Paul Gardner, actually what you asked me, I asked Paul Gardner that why you are removing hippocampus through the nose and then orbit. And also in US now the trend is non-resective, laser ablations. So they are going for laser ablations, and Paul Gardner is telling that you learn epilepsy surgery, you learn endoscopic surgery, and then you remove all those things, making it things much more complicated. But these are all options. These are all, I mean, that's probably how things will evolve, and it's a test of time. After maybe 5 years, 10 years, if once lasers come to India, if lasers become available and affordable, more people will learn about laser ablation than endoscopic removal of the hippocampus through the nose and eye, because we'll have a lot of learning curve and complications, CSF leak, a lot of problems will be there. Such a benign condition, such a curative condition, we cannot afford to have complications. But these are all, that's how experimental therapies, experimental surgeries will evolve. Yeah.
So just remove a small focus cell laser thermocoagulation or RF thermocoagulation. We have started doing that, but for very focal lesions.
Yeah.
So when there is a very strongly suspected network disease, do you think such minimalistic approaches will succeed? For example, here most of the expenses in India are out-of-pocket expenses.
Yeah. No, it's a very important. It's very important point. Probably in epilepsy surgery, we cannot afford to have failures. I mean, it's disheartening to the patient and then family, and to the operating surgeon also. I think there are. I'll answer your question by two points maybe. One is like, if you compare epilepsy to terrorism, there is a terror network, and then among the terrorists there are some key leaders are there, prominent leaders. If you eliminate them, it will have an impact on the network. So that is like what is what are the important nodes in the epilepsy network is very important. And some progress is happening in this regard. There are a couple of papers were published recently. After stereo EEG implantation, all the data is fed into building a virtual epilepsy surgery patient, and then you do surgery on the system virtually and then see which nodes can be eliminated. So this system will give the outcome. Okay, you remove these two, outcome 40% cure. You remove this also, outcome 60%, 70%. The system will give the percentage. Based on that information, you can tailor your surgery to what all areas to be resected or ablated. But this is based on stereo EEG, which itself is a limitation. So post stereo EEG we can plan. But what is interesting is that it will give information about the whole brain network. Stereo EEG, you put 8 electrodes, you sample 8 areas, but the virtual model will tell about the whole brain. Even where electrodes are not implanted also will be part of the network, and what is their role, all those things. Very interesting papers are coming out. Of course, artificial intelligence and machine learning, they will change the way epilepsy surgery is going to be done in the near future. Yeah.
Let me invite, thank you sir for the excellent talk.
Yeah.
Let me invite Dr. Arivargan for the next talk. I just had one small comment, sir.
Yeah.
There is a significant segment of patients who fail in epilepsy.
Yeah.
Epilepsy surgery.
Yeah.
And you suggested that CHITRA should have a new mandate to work on. I had a suggestion that we must start a center for all the failed epilepsies of the country. Failed epilepsy surgeries can be collected.
No, I think it's already happening for
Exactly. This is CABG. So this can be this one. You can collect all. You can put up this one that we will go for ultra fine workup of all the failed epilepsies.
I think they will teach us more than the successful cases.
Exactly.
Good afternoon. I thank CHITRA Institute and the organizers for inviting me here. Last time I came here, I was a student, and I think after many long years, I've come. I still like to be a student here. Such a nice place, very jovial atmosphere, and oh, sir, many years. And my gratitude and regards to Professor Bhattacharya. He was our teacher here and our examiner in NIMHANS. And going to the topic that I was given to talk, it's a long session, and looking at the session, I thought, I was like, what I have to talk, because there are big names above and big names below, and so I tried to cut short what I was initially intending to talk. So I'm just going to concentrate on basic principles in temporal lesions causing drug-resistant epilepsy, and how do we make decision in these patients, and what surgical techniques we use to achieve the best surgical outcome. So we all know hippocampal sclerosis is the most common cause of drug-resistant epilepsy, which is surgically remediable. And second comes the list of a whole lot of tumors, which form about 1/4 of all the causes, all the etiologies which are surgically remediable conditions which cause drug-resistant epilepsy. Among the tumors across various studies, gangliogloma being the most frequent, and some DNETs are most frequent. If you look at the tumors, whether all tumors cause seizure with the same incidence, it's not so. So this slide shows various histologies of tumors and what is the chance of them causing seizures. If you look at the names on the top, DNET and gangliogloma will present with or will cause seizure in almost 90 to 100% of all patients, whereas lesions like metastasis or CNS lymphoma will cause anywhere from 10 to 35%. So even among tumors, the epileptogenesis or the tendency to cause seizures differ, and this can be due to various causes. It can be tumor-related factors, it can be the peritumoral changes that these tumors bring in, and also the brain networks that form around these tumors due to various immunological, inflammatory, as well as various metabolic changes. So if you look, I'm going to talk only about these tumors which cause drug-resistant epilepsy, and where we do surgery for controlling seizures and not just for tumor removal. So if you look at the histologies, they are grossly divided into glioneuronal tumors and glial tumors. And we should remember that this was a point again was mentioned before, that many of these tumors, especially DNET, can have associated pathologies like FCD and other lesions which can be the cause of the seizure. So this was the recent data that we analyzed among the last odd 500 specimens that we operated in last decade. 72 patients were operated for lesions, and again, as you see in our list, the ganglioglioma and the DNET top the list, and whereas other tumors like PXA and DIGs form a small number. So when we decide for surgery for these lesions causing epilepsy, again I'm going to focus on temporal lobe because that was what the top. I'm not going to talk much on the extratemporal lesions. We have to understand MRI shows a lesion, but we have to look into a holistic evaluation. Like all the investigations have to be done. If you don't do an EEG, if you don't do a sometimes PET, we will miss a particular lesion where the epileptogenesis is beyond the lesion, and then in which case surgery alone will not cause seizure control. So in addition to finding the lesion in MRI, we have to identify the epileptogenic zone, and the surgery will be dependent on the location of the lesion and the proximity to eloquent cortex, especially in extratemporal, and associated pathologies in these lesions. And various adjuncts are used for these patients during surgery. So why tumor causes a seizure? The exact mechanism is still not known. Whether the neuronal component of the tumor causes seizure, or is it the adjacent changes that happen, adjacent cortical areas which undergo glial or a dysplastic reorganization around the tumor which causes seizure. And it is also identified in many studies that the adjacent cortical areas, especially those who cause in tumors which cause drug-resistant epilepsy, do undergo synchronization of local networks and can become the actual focus of seizures and not the lesion per se. That's where you have to be able to identify them and remove them to cause good seizure control. So the goal of surgery in these patients is to control seizures and not just to remove tumors. This has to be understood well so that to have a better outcome. So what is the extent of resection? This question keeps on coming again and again, whether removal of lesion alone is enough or we need to tailor the resection. If you have to tailor the resection, do we tailor them based on ECOG or based on other modalities, investigations that based on PET or EEG findings? Or there may be in patients with EEG and semiology analysis, there will be some red flags which say that this is just not the temporal lobe seizure, there is something beyond that, or sometimes a PET MR will show very elaborate or widespread hypometabolism, indicating that the network is already reached well beyond the lesion. So all these are required before taking decisions. So again, focusing to temporal lobe, this is what we follow, and this is the paper that I'll go to the next slide. Depending upon the location of the lesion in the temporal lobe, the area of the lesion removal, the area of the brain removal may vary. For if a lesion which is involving a lateral temporal lobe, superior or middle temporal gyrus, it is sufficient to remove the lesion alone without removal of the mesial temporal structures. Whereas if the lesion is involving the temporooccipital gyrus or the mesial temporal structures, then most often removal of amygdala and hippocampus will be necessary, because they would have already become an epileptogenic zone and network, and non-removal of that would actually cause reduction in seizure control, or will cause less chances of seizure control, meaning recurrence will be high. So there are papers which have talked about this. Again, to reiterate why this is important, patients with temporal lobe lesion, the electrophysiological studies have shown that the hippocampus and mesial temporal structures, when you put IEG, they can be an independent seizure generated in up to 94% of patients. And therefore, like for example, in mesio-basal lesions, the mesial structures are epileptogenic and should be resected even in the absence of imaging abnormalities, thereby to achieve a seizure control. You may remove the lesion, tumor, but seizure may not be controlled if the mesial temporal structures are not removed along with that. So a few case examples. This is a 20-year-old boy who presented with seizure for 1 year, and you can see a small lesion in the right posterior temporal lobe, and a PET is concordant showing his focal hypometabolism, and MEG was inconclusive. And this patient, as I said before, this lesion is away from mesial temporal structures and well posterior, focal lesion, and this patient required only surgical removal of the lesion and did not have to have any further. We as a, since there was a presentation of Srinath before, we use electrocardiography in all these lesions, other than those anterior temporal and mesial temporal structures where we do not use ECOG, but otherwise anything which is beyond the standard ATL, if there is a lesion, we use ECOG for guiding. And this patient did not require further resection, and this was sufficient. However, if you look at another patient, this is a 16-year-old boy who had a small enhancing lesion in the region of left amygdala, presenting with drug-resistant epilepsy. If you look at it, this patient also had associated hippocampal sclerosis. There was some atrophy of the left hippocampus. So this patient, if we do surgery and remove only the lesion, the chance of him having seizure control will not be significant, and therefore in this patient we would remove the lesion. In addition to the lesion, we would also do a complete amygdalohippocampectomy for seizure control. This another patient with 26-year-old lady presented with seizure for 8 years, as opposed to the previous patient who had a seizure for only 1 year. This was a point Dr. Matthew was making at that time. Long-standing seizure, multiple drugs. Video EEG is confirming that the seizure is coming from right temporal zone and a focal temporal hypermetabolism. So this patient underwent surgery of removal of lesion and intraoperative ECOG. And during surgery, we noted that after opening the temporal horn, the amygdala and hippocampus was firm and had adhesions, and therefore we completed the resection of amygdala hippocampus also to make sure that the seizure control is optimal. So coming to the this point of understanding, a patient with cavernoma. This is a young lady who had only one seizure, large cavernoma in the left temporal region. So this is not a drug-resistant epilepsy. So this patient, we would not require any evaluation for a drug-resistant epilepsy at all. And here the surgical principle is to only remove the lesion, and that's what she underwent, and resection of the cavernoma alone. Compare that patient with this patient. This is another 30-year-old lady who has been having seizure for 15 years and having seizure 4 to 5 times per week on 3 anti-epileptic drugs. Again a cavernoma, this time right side, right temporal, involving the region of amygdala, and PET showing hypermetabolism. In this patient, if we do, and EEG also showed from right temporal origin. In this patient, if we do only temporal exposure and if we exercise only the cavernoma, the chance of her getting seizure control will be very less, because she is having daily seizures now on multiple drugs for 15 years. And so this patient underwent a complete temporal lobectomy as well as anterior temporal lobectomy and amygdalohippocampectomy in addition to the lesion resection. So the point here is we have to tailor our surgery based on the location of the lesion, based on the long-standing seizure and medications, and we have to understand that one size will not fit all. Sometimes the lesions which cause drug-resistant epilepsy, so far I showed small lesions, but sometimes they can be very big and very diffuse, and we may be able to excise them completely and may not. Sometimes, like in this case, you can see a large DNET involving the whole of right temporal lobe and also extending into the insula as well as into the basal ganglia. And here we resected the lesion up to the region of insula, and there is some residue in the region of the basal ganglia, still an insula, but this patient is seizure free after 4 years and had a good seizure control. Probably it indicates here that if you remove the epileptogenic focus and disrupt the networks, even if there is a residual lesion, these patients can achieve seizure control. But again, it is sometimes which the answer will get only by long standing waiting and watching. You cannot. This is another patient who had this seizure who had this tumor for 7 years, having only drug-resistant epilepsy and multiple drugs, a large lesion involving the right temporal lobe. Despite such a large lesion, the mass effect on the surrounding brain is less, and he underwent surgery and resection of the lesion, and now 1 year now since surgery is seizure control. There is some amount of residue near the region of the basic temporal region, which is I could not remove that. So when we talk about lesions, we have to remember this lesion can be associated with FCDs. They can be FCD2 or FCD1. What is the difference is FCD1 is a very subtle dysplasia which is often not picked up in the MRI, or they will be just seen as a small streak, The FCD2 is a balloon cell dysplasia where it is more obvious. And they are again labeled as 3 and 3B various classifications by the pathologist. And in these patients where there is a lesion with additional pathologies, ECOG is, I think, in my understanding, mandatory, because otherwise we'll miss those areas and will not achieve a optimal seizure outcome. There's few cases. An example here you can see there is a lesion here as well as a hippocampal sclerosis in this patient who presented with drug-resistant epilepsy for 15 years. Daily seizures for 4 to 5 episodes every day. Video EG and MEG is concordant. And in this patient, even though the lesion is at the inferior temporal gyrus, we would operate and remove the lesion. In addition to that, we would remove the mesial temporal structures to have a good seizure control. And this was a dual pathology showing ganglioglioma and hippocampal sclerosis. Last case, which I would like to show just for completion, that the lesions can also be present in case of lesions in extratemporal, the whole gamut of investigations as well as adjuncts come into play, especially when they are in the eloquent cortex. We need to remove the lesion. We will have to balance our surgery to get adequate seizure control at the same time to preserve the functions, especially if the lesion is in or adjacent to eloquent cortex. We need all these adjuncts to map the functional area, remove the lesion, do awake surgery, intraoperative monitoring, and make sure we remove the lesion at the same time cause less or no deficit if possible. But the goal has to be to get a good seizure control, because these people come with a drug-resistant epilepsy having almost daily seizures. So this young lady, seizure for 3 years, lesion is exact on the adjacent to the motor cortex medially, and she underwent awake surgery, mapping of the motor cortex, and phase reversal to identify the motor cortex, and then stimulation of cortex as well as subcortical fibers, and then and stimulate and identify the function. And while removal also make sure that you monitor the hand function and leg function. And she is seizure free now for 3 years. The lesion is excised and has no deficits. And this was ganglioglioma. So what are the outcomes? If you do all that, do we get good outcome? Yes, that's a whole fruit of the whole all this effort that we put in these patients who have been having seizures, many of them having daily seizures on multiple drugs. Once we do all these techniques and make sure that the lesion as well as epileptogenic zone is removed, more than 80 to 85% of them have seizure freedom. The Engel 1 outcome is like they are completely free of seizures, and they can be tapered off medicines, and they can get back to a good quality of life post surgery. And we have a lot of papers. This paper is from here CHITRA, which they have shown nearly 80% seizure good outcome, favorable outcome across various lesions operated at CHITRA. Number you can see almost 100. This is a previous paper. This paper is from NIMHANS, where we analyzed this many years ago. The latest data is still yet to be published. This is about again more than 75 to 80% seizure control Engel 1 outcome across various tumors. And what we need to remember is these patients have to be operated early. So what are the factors which can influence outcome? Shorter duration of epilepsy before surgery, location. If it's a single EEG focus, it gives a better seizure freedom. And this line is what we need to remember. A probability of unfavorable outcome increases as we wait longer. And to summarize, early surgical intervention and good seizure control is possible with all the with appropriate and complete investigations. So to summarize, lesions are the second most common cause for drug-resistant epilepsy in patients, and among them DNET and the gangliogliomas have a almost 100% chance of causing seizures and present drug-resistant epilepsy. Early surgical treatment will result in good quality of life. A comprehensive pre-surgical evaluation is essential so that we know that what we need to remove. There may be, if you operate all these patients without any of this, they may still do well, but there will be a percentage of patients who will not do well, will continue to have seizure, and that time we will have no idea what we need to do again. And we need to recognize associated pathologies in these conditions, and if we miss them, they will be the reason for bad outcome. And those lesions which are close to eloquent cortex have to be dealt with a balance of seizure control and functional preservation using all the appropriate adjuncts. Thank you. So this is our group at NIMHANS. It is not a one person's work, it's a group work. Thank you.
Yeah, thank you, Hari. Any questions or comments? Yeah, thank you, Hari.
I have one question, sir. Sir, in generally epilepsy surgery, we do either resective or disconnective procedures. In the temporal lobe pathology, non-lesional temporal lobe pathology, is there any role of disconnection, only disconnecting the temporal lobe from the rest of the hemisphere? Whether any information?
Disconnection of the temporal lobe.
Like how we do temporal lobe resection. Is it just disconnect and leave it temporal lobe? Is there any?
See, usually if it's a focal, disconnections are usually done when you have to remove a lot more brain, where the cavity can give problems, and the surgery becomes more elaborate. So that is where we do either an anterior disconnection or a posterior disconnection or a hemispherotomy. So if it is a focal pathology involving temporal lobe, resection, this Dr. Bhaskar keeps telling us every time in our PMC meeting, resection is better than disconnection. Another sentence I'll again repeat, 90% disconnection is not disconnection. 10% will cause a problem. If you resect, there is a difference. So if it's a focal pathology in temporal lobe, we always resect. That said, there are papers which talk about disconnection in temporal lobe, which is called as hippocampal disconnection. Lot of papers have come. I think one Dr. Angelo Patel, he had worked in St. John's before, he is now in US. And there are papers which talk about hippocampal transections, where you don't, in case of even in mesial temporal sclerosis, you don't remove the hippocampus. You go and do horizontal transections perpendicular to the direction of the hippocampus, and that they have shown that it gives equivalent response in seizure outcome compared to hippocampal resections. And they also, there are some papers with small number of patients which show that the neuropsychological outcome in these patients are better. So maybe in that context, if you preserve the lobe, that neuropsychological outcome may be better. But I don't think we follow that disconnecting temporal lobe alone and leaving in our practice.
Thank you, sir.
Thank you.
Thank you, Hari. May I call upon the next speaker, Dr. Ashok Pillai, for his talk.
While they're connecting, I want to thank my friends Dr. George and Dr. Matthew for having me here. It's an honor to be presenting to you at one of the birthplaces of epilepsy surgery in India. What I decided to talk upon today is, I've modeled it mainly as a philosophical talk, not a technical talk, because this is something in my experience recently in the past 2-3 years which has been occupying more of my thoughts. What are we to do? There's a lot of changing technology, and it's very easy for me because all the questions have already been asked in this same session. I'll try to answer some of those with my thoughts and experience, and it's not really that much of a technical talk or database talk. But upon reflecting on this, it's a continuum. As you see beautifully in Professor Bhaskar Rao's talk today, it's a continuum. You cannot separate yesterday from today. What I think today is going to form tomorrow. And what I did yesterday made me who I am today. So we all know this. But for us, as you see in the questions asked, especially, for example, what Dr. Ravi Rao sir asked, we're at a position where we have to ask ourselves some of these questions, what to do next. There are different options. There's like an explosion of technology also. Actually, I wasn't aware of the transnasal approaches. It's not a problem because I won't be doing it ever. But you have many options. So I always like to take a step back, because if you look at anything in life, what our thoughts are what form our actions. And it's basically what we understand, what we intend to do. So what is the philosophy here? It's already been highlighted in the previous talks. In epilepsy surgery, we want seizure freedom. We shouldn't lose sight of that goal. We want seizure freedom. We want to preserve function. We want to improve quality of life. Actually, we don't really, it doesn't matter whether we're minimally invasive or maximally invasive, provided we can achieve these 3 goals. That is, achieving seizure freedom, preserving function, and avoiding complications. Sometimes that might require a maximally invasive surgery. And many times,
I'll go through a case-based approach. The simple thing, temporal lobe epilepsy, as we've already seen, this is one of the stars of epilepsy surgery because it has such a good outcome. Let's go back to when this started. This is a fascinating paper. Some of you may have read it. This is the first paper by Dr. Penfield in the 1950s that described how they discovered the origin of seizures in temporal lobe epilepsy. It was work between Dr. Penfield and Jasper, and Dr. Jasper had just been developing EEG. It was initially developed as a tool for psychiatric illness. It is when he came in with Dr. Penfield on awake surgeries and started doing electrocardiogram that they realized the correlation between spikes generated from the temporal lobe and epilepsy, and then tried to localize it. But very interestingly, what they did is they did not know that the hippocampus is actually the pathological substrate in temporal lobe epilepsy. If you see, out of the series of 68 patients, the hippocampus was removed in only 2 patients. If we look at that today, we'll wonder what kind of temporal lobe epilepsy surgery that was. Yet they had 52% success, and many of those actually were cured. That means they didn't have any more attacks. So that's quite significant. And that actually proves to me that it's a network disease, as Dr. Avimon rightly brought up. You have a network which is well demonstrated between the hippocampus, and not only the hippocampus, but between the lateral temporal neocortex. This has been subsequently well studied scientifically through stereo EEG, documented with connectivity studies. The temporal or even source localization of the spikes that you see on an EEG actually doesn't come from the hippocampus. It comes from the temporopolar neocortex. In one of our recent studies looking at volumetric asymmetry in MRI and PET, we also noticed the exact same thing in a statistically significant way, that the temporopolar cortex is very much involved. So you have a local network in routine temporal lobe epilepsy, which is probably why the initial surgeries worked just as well. Now let's take that to the, and from that we all know that this operation has resulted. I'm not going to go into detail of the operation, of course, because most of you here know how to do it very well, or it is nothing new. Now the main question is, should this be replaced? Now, now have been training fellows for the past 8 years. In my experience, it is one of the hardest things to teach a fellow or a resident to take out or do a good hippocampectomy. There's a certain fear element. I think many of us who have gone through it, we have that fear element. How to go measly, how to preserve vessels, and how not to have a stroke. If you remember back to your initial days, those of you who do the surgery in so many numbers now, you remember that. Now, this identifies an important reason for why people are moving away from it. Is it fear of learning something difficult? Or is it that the newer things are actually better? We really have to ask ourselves this question. Because the temporal lobectomy, which you see here, which we were talking about so much, was described by Dr. Pete Engel in the 1990s as the most underutilized operation of the century. Simply because, am I correct, sir? The most underutilized operation of the century, simply because the result is so good, it can be learned well, and the effect on the individual's life is profound. I'm afraid, however, that it may be totally unutilized in this century, because if you look at present trends in North America, and I was recently there working, and I noticed that people cannot do a good temporal lobectomy. Okay, microsurgical technique, you can only do a good anterior temporal lobectomy if you can do other microneurosurgery also. If you simply go straight into learning stereotactic functional neurosurgery and you learn how to ablate something, you haven't learned the other. And is this a trend that we really want to see happen? It's a very important question that we have to ask ourselves. I'm not here to answer the question and say yes or no, but it's something that we have to really talk about. But let's look at what is the result of these things. Now, this has been the question about evolving laser technology has been asked. The best comparison available, short of a randomized trial, which doesn't exist and has not been started yet, was a matched non-inferiority trial recently presented on just laser ablation in general as compared to open epilepsy surgery, trying to prove non-inferiority, and it failed to prove non-inferiority in seizure outcome, meaning that a laser ablation is, as far as we know, slightly inferior in achieving a seizure outcome, with the benefit that it has a better safety profile and shorter hospital stays, for which it was also developed. So let's see, what do we do in the anterior temporal lobectomy or the hippocampectomy? You systematically identify the important anatomic structures, and you, under your vision and hands, are removing that. Now you've removed the dentate gyrus, the parahippocampal gyrus. If you're good and you've studied it well, you will remove do a good amygdala resection and a piriform cortex excision. And this has been studied in the 1990s, the extent of these things, trying to relate it to seizure outcome. In the present thing, we're reducing that to a simple trajectory with a geometric shape. You can only achieve a cylindrical ablation with one trajectory. And so you will need two trajectories, two probes, to cover this much. And then you do still have, depending on how your trajectory enters, you do still have residue of the posterior parahippocampal gyrus, which has been identified as a significant epileptogenic substrate in the past. You very frequently have a significant residue in the piriform cortex, just subpile along the sylvian fissure, which is also well identified as an epileptogenic substrate. These are only the mesiotemporal structures. Now, let alone the entire mesiotemporal, lateral temporal neocortical network, which hasn't been touched at all. So this is something that I actually learned, and I learned it from none other than Dr. Robert Gross, and I thank him very much for the experience. It is interesting, and it's important to be updated in technologies, I agree. But so we are avoiding the craniotomy and using thermal energy. Now, let's look at what are the seizure outcomes. We have various documented cohort series between 55 and 70%. The main thing which I'd like to highlight is it is being studied and promoted as something with good neuropsychological outcomes, which is well documented. It seems to be favorable, and you don't have a head-to-head comparison, but if you look at the matched comparisons of neuropsychological data, that seems to be one benefit. Seizure freedom in the largest meta-analysis is about 58%. Let's look at, but again, the benefit of the laser therapy in temporal lobe epilepsy is definitely reduced morbidity and even reduced mortality. So you don't see deaths in an SLAH. You shouldn't see it in epilepsy surgery in general, but we all know if you start doing 500 or 1,000, you may have one. In my own personal series, I have had 4 very unfortunate hemiplegias, 2 of whom recovered completely and 2 who were still disabled. This is one of the most the fearsome point of a temporal lobectomy. Generally, now I have had hydrocephalus requiring a shunt in an older patient. We all know that from well-published literature, the risk of complications is higher in older patients with temporal lobe epilepsy. This is important when you're faced with a patient in their late 40s, 50s, 60s, and 70s. I've even had an unfortunate death from a temporal lobectomy, unrelated to the surgery, but related to postoperative complications from acute postoperative seizures. As Bhaskar also had already explained his seminal publication, this can be a significant problem also with an open surgery. But does the neuropsychological data itself really, what does it mean? We have to really sit down and look at that in a longitudinal fashion over time as well, rather than a single score or a certain point in time. I had this conversation with a good friend of mine, Dr. Urvashi Shah, who has done so much important work in the neuropsychology of epilepsy surgery and temporal lobe epilepsy surgery. And she has just been in the process of analyzing the exact same question. What does it mean to do cognitive and neuropsychological rehabilitation after a temporal lobectomy? So which is the worst temporal lobectomy patient who can take what we call a hit, a memory hit? These are the ones who have normal neuropsychological profile, right, and you're doing a dominant sided temporal lobe epilepsy surgery. When they looked at it, out of 145 patients, and this is recent unpublished data, I'm very thankful to her from their team for sharing this with me. I hope to see this in publication from their side soon. They had 28% who had a measurable hit in memory when their pre-op neuropsychological score was good and normal. Again, you have to remember that LIT is being promoted for temporal lobe epilepsy surgery in general when they already have neuropsychological deficits, which is probably more the majority of patients. But of these who had preserved pre-op neuropsychological function, only 9 out of 145 actually had increased subjective complaints, which is a very small number. And they subjected these patients to compensatory strategies, rehabilitation, and over 3 years, they were able to cope and were no longer distressed by these things. Now, this is an important thing, is this is an alternative to minimally invasive surgery for temporal lobe epilepsy, when we know that the routine temporal lobe epilepsy surgery promises better things in the long term. And what is the seizure freedom actually in temporal lobectomy? Well, we know the well-known randomized trial, 58% quoted. Another important, well-cited meta-analysis up to multiple cohorts up to about 2001, giving a median seizure freedom of 70. However, and when I had this discussion with Dr. Gross in particular, the question was, well, can you really get that good at the surgery? Is it just that the surgical technique can improve your outcome from 60 to 90%? And yes, it can. And they're well published series. Now, these are retrospective, 89%, 92%. In my own series, when we have recently submitted a manuscript, which will come out soon, in using unilateral temporal lobe surgery for what we have designated as actual bitemporal lobe disease to break the network, again, we still saw close to 90%, whichever cohort we used. So if we practice the surgery well and we try to perfect a routine traditional surgery, it may still be better than the new things coming up. And we should never lose sight of that fact, that's one of my main messages. What are the options coming for difficult temporal lobe epilepsy? As I showed the bilateral temporal lobe epilepsy, we have to be aware of neuromodulation. It has a significant role. We have the well-designed and completed Sante trial looking at thalamic DBS, and you obviously have neuromodulation with neuropaces. These are evolving technologies with evolving data sets. They have their own limitations also. One of the best things about RNS is that you can use it as a chronic recorder rather than a stimulator. And then one trend in North America right now is if you put in the neuropace, you lateralize over 2-3 months, and then they go in for surgery and still do what they call a destructive procedure. Maybe it might be a laser, maybe it might actually be a temporal lobectomy. And so we have to be aware of these things also. So you see that now we have to make decisions. We have in unilateral temporal lobe epilepsy, we are faced with decisions of the traditional surgery, which probably still offers a better long-term seizure freedom and even drug freedom, which is well documented from this same very center. And this might be the best thing for the patient when combined with cognitive rehab instead of trying to go for a simple minimally invasive thing. When you have bilateral temporal lobe epilepsy, we're faced with the option of neuromodulation or still going with the traditional temporal lobe surgery. There's a very well published series from KEM Medical College showing the same thing. Now, having learned that, I still do thermal lesioning. This is a patient with normal neuropsychological profiling and MRI negative, in which I did a selective lesioning. And he's doing well with seizure freedom at 5 years and on drug tapering. And I may have helped his neuropsychological profiling. So it's good to know both, and I think that's important. But that requires a certain culture of not rejecting the past. So at present, my protocol for using stereotactic thermal lesioning and TLE is what I call high-risk TLE. That means I offer it to patients over age 45 because my own complication rate is higher. The reported complication rates are higher with the craniotomy. Medical comorbidities, which are relative contraindication to a craniotomy, and then perhaps the bilateral temporal lobe epilepsy when the outcome may not be as good. Now, I put this here just because that's the topic. The topic. When I was there learning focused ultrasound, it is something I never had an interest in before for many reasons, but I learned that it's a very interesting modality and it has a future. Just the virtue of being non-invasive brings in a certain different population of patients who are not ready to take a bigger risk. And lo and behold, the cadaveric studies are there where you can reach the anterior and posterior medial temporal lobe structures with MR-guided focus ultrasound in cadavers, and there is a single case report. This is something that may develop in the next 10 to 20 years. This would actually be very different from LIT because it's still non-invasive. It can be done as the trial before the actual craniotomy. That is a very reasonable, and actually regarding the dilemma and discussion that we had earlier, the cost of focused ultrasound, once you increase once you expand the spectrum of applications per patient, will come down significantly compared to LIT, which requires a $10,000 US probe per patient. So if we expand the applications of a single modality, which is a hardware, which has less consumables, this may offer better non-invasive, non-invasive, not even minimally invasive solution. Moving on to a similar situation. Now, the table turns when you go to a scenario in epilepsy surgery where the outcomes are not as good as the traditional temporal lobe epilepsy. I will present a case here which we just reoperated this week and reminded me about a lot of these things. This is an MRI negative patient who had hypermotor seizures, and the MRI was normal. We were able to use advanced imaging of PET and SysCom to localize to, combined with the electroclinical evolution, to localize to the temporoinsular network, and an SCG was done and showed clear onsets from the posterior inferior insula. This was done about 2.5 years ago. And from our experience, which has been published, in my experience, the risk of posterior insular surgery was higher for me, with higher deficits. We had already developed our thermal lesioning, and we saw that with the thermal lesioning, that is RFA, I had only 0.27% versus a higher chance of deficits with resection. I don't see a lesion. An SEG onset is sometimes not good enough for me to do a more invasive surgery, so we went and lesioned. And lesioning is a trial lesioning. It is not actually meant, it is going to fail. It is understood that it is going to fail. It is to see, it's to give a therapeutic challenge and see what happens. And lo and behold, after he underwent this lesioning, he went from daily seizures to being seizure-free for 10 months. That helps us now convert non-lesional into lesional epilepsy, because we can now see what has been lesioned. He gradually relapsed and still hasn't reached his initial seizure frequency, but was interested in achieving long-term seizure freedom and has come back. So this is a relapse. It's not really failed epilepsy surgery. And we have a dedicated discussion for what we call a relapse conference. So we know that from European literature that if you respond to thermal lesioning, the chance of getting long-term seizure freedom, if you convert that to a resection, is very high. It's about 80 to 90%. And my own experience is similar to that. Upon relapse, then we reviewed his previous stereo EEG, and then we confirmed that these are epileptic with a video EEG.
I think you're overshot time.
Sure. And so this identifies that, and then we convert to do the traditional surgery. So what has happened now? In the initial case, traditional surgery gets you to the goal. In newer cases, now you can undertake more difficult things, but you still need all the tools that you learned before. SCG is there, the thermal lesion trial helps there. On relapse, then we use the traditional surgery to get back there. So I think non-lesional surgery, the epilepsy surgery, the way forward would be to optimize. Now we have an experience of 268 stereo EEGs. We try to optimize image acquisition, optimize image post-processing, optimize stereo EEG, and expanding the role of these trial therapeutic ablations and neuromodulation. I added these slides just now because there was discussion on HFO. We have a manuscript coming out soon on how on physiologic versus pathologic. That is probably the most difficult thing, is differentiating physiological from pathological HFOs, because HFOs are more commonly physiologic than pathologic. It's more the rate of that. Neuromodulation, because we're talking about the future, evolving. The technique is improving, results are improving. It takes time, and it's largely related to targets and programming. We are developing our own experience there with multi-target DBS, and in the difficult cases, especially non-lesional. I'll quickly go through hypothalamic hematomas because I feel this is a situation where we see the opposite. We've gone from maximally invasive surgeries with high complication rates to more minimally invasive approaches, because we're still following a good result with low side effect profile. This is the technique that we use for stereotactic RFTC, and you can see that thermal lesioning causes a disconnection of the hypothalamic hematoma. And we have very good results with this. I'll be happy to discuss it more in detail with anybody who has an interest. But here's something which is very good use for MR-guided focused ultrasound, because it is ideally suited for that region around the MCP, the mid-commissural point, and you have real-time imaging of the thermal lesioning. You have very good precision. So that may be coming in the future. The technical difficulties include using thermal lesioning in children, which is not really well documented yet. Further areas which I would have liked to talk about balancing is improvements in pre-surgical technology and localization, surgical planning, understanding pathology and outcomes. Many times I feel we have to understand pathology more. So in conclusion, I think our responsibility is to improve quality of life. That includes delivering results, preserving function, and reducing morbidity. And our responsibility is innovation to only deliver better results while preserving this function and reducing morbidity. We actually don't have any direct responsibility to promote a given modality, technology, or procedure unless it delivers this. And finally, our success will lie in improving both skill and technology, not at the cost of one, or not sacrificing one at the cost of the other. So this is one problem which is happening, a trend is happening in general. We may lose the skill of traditional microneurosurgery at the cost of inferior outcomes. Thank you.
Yeah, thank you, Dr. Ashok. May I call upon Dr. Rahimohan Rao for his talk? I think we have far exceeded the time, so we will have discussion later on once the session is over. Thank you.
Just a small announcement, sir. There's a tea arranged outside. In need of time, we'll continue the session. So feel free to take tea and then come back for the session while the session is ongoing.
All single picture slides.
No.
So
the chairpersons are stuck here, please announce that you can go first.
I'm very thankful to Professor Ishwar and Professor George Villanilam for accommodating me. I actually requested them to accommodate me so that I could talk on epilepsy surgery in the private sector. And if you look at this slide, I want to convey that we stand on the shoulders of several people before us, which includes our teachers, both within the institute and from outside the country. And of course, Professor Radhakrishna, Malla Bhaskar Rao, Herbert Sylvanus, I learned the technique of doing hemispherotomy from him. And Professor Bhattacharya, Professor Suresh Nairu encouraged me to take up and do epilepsy surgery. If you look at the right-hand side, this is what Dr. Malla Bhaskar Rao was telling. And you see 9 neurologists, 7 are neurologists and 2 are neurosurgeons, with whom I have done epilepsy surgery in different parts of the country. And if you look at this, 99% are from CHITRA. They are not from other institutes. So the first name and Dr. Sujit Kumar are 2 of them with whom I work, do my maximum number of epilepsy surgeries. And of course, when I first moved into the private sector, I started my work with Raghavendra Dinesh Naik and Rajesh Shankar Iyer in Coimbatore. And after working with him for a certain time period, now Biji Bahalian has taken over. And so 7-8 centers are doing epilepsy surgery as a result of starting this work. Now I go back to my first slide. So this is my hospital. From the front, it looks very small, like a railway compartment, but it's more anteroposteriorly long than transversely wide. So it looks like that in the picture. And this is my neurosciences team, which includes neurologists, neurosurgeons, anesthetists, interventional radiologists, and diagnostic radiology technicians who help us in our combined work. So this is the Bangalore Neurosciences group. Dr. Sujat is the main epileptologist. And now we are joined by 2 more, Sindhu and Jayant from NIMANS. And Dr. Dinesh Naik is here. One thing I want to tell about Dinesh Naik is he's a fantastic neurologist and epileptologist. In fact, the way of working up an epilepsy patient, I showed all the names. Most of them have learnt it from him. His technique is to do a thorough clinical history taking, and from that he is able to tell the lateralization and localization of the lobe without looking at the MRI scan or the video EG. So his first step is a very thorough clinical examination, history taking and examination of the patient, forming a hypothesis based on that alone. And we have seen that work practically in most of our cases. And when we look at the MRI or we try to explain the video EG, we do it in light of the clinical findings. Dr. Rajesh Shankar Iyer, Dr. Venkatswamy in Hyderabad. So there are several things involved in epilepsy surgery in private sector. There are myths, challenges, the need to work with passion and determination, and the need to form a nucleus of 2 to 3 committed professionals and build around them. One of the myths that you hear frequently, at least when I started first doing epilepsy surgery in Bangalore, is that it's not possible or very difficult to do epilepsy surgery in private sector consistently. One may do anecdotally 1 or 2 cases, but to consistently do it month after month throughout the year is a very difficult thing which is possible only in the institutes. And that myth exists because of the challenges that are there in the private sector. One is convincing patients. It's one thing to convince a patient in CHITRA or NIMHANS or All India Institute to undergo surgery, and it's a totally different thing to convince a patient in the private sector to undergo surgery, saying that it would benefit him or her enormously, reduce the disease burden, possibly make them drug-free, possibly improve their neuropsychology, possibly improve their social life. So it requires a lot of convincing to tell the patients. And some of these patients want to talk to other patients who have undergone surgery earlier and have benefited from it. This means it's like the chicken and egg question. You need to have some patients whom you can refer them to go and speak. So you need to have done a few cases already. So it becomes much more difficult to convince patients. The third factor is prolonged investigations and its expenses. One is video EG, which needs to be done for 3 days, 4 days, 5 days. If the patient is suffering from seizures 2-3 times a month, you have to taper the anti-epileptic drugs, do prolonged video EG 24 hours, 36 hours, 72 hours, which means one is the cost, second one is the long duration it takes to finish the testing. And when you do the test, it's not that the test alone is important. It's the neurologist who sees and reports it. He or she needs to have the passion to spend that much time reviewing it every day. One of the saying I've heard quite frequently is, if a neurologist can see one patient of epilepsy in private sector, another neurologist can see 20 patients in the same time that one neurologist spends on a single epilepsy patient, doing all this video EG analysis, looking at the MRI, getting the PET brain done. In some cases, we do the MEG, and then, of course, the stereo EG. We have started applying stereo EG in our epilepsy patients more frequently as per indications. Then comes the role of the neurosurgeon explaining the surgical process, the procedure, the success and failure rates and complications associated with it. This is a big job. You need to spend nearly 45 minutes to 1 hour to tell the patients. They have many questions. You need to have models to show them what to do. Then comes the question of surgical failures. You need to keep these patients with you, and you have to reinvestigate a surgical failure, and if you happen to come to a quick conclusion, you have to offer reoperation. So during this entire process, the patient needs to stick to you. I work in a city where NIMHANS is next door, and CHITRA is just 45 minutes away by flight, and by train it's a few hours away. So you need the patient to stick with you to go ahead with tackling the failures. So how do you solve the difficulty in getting patients, you need to launch an awareness blitz. There are many people who are very good academicians but are not good private practitioners. You need to have an awareness blitz to create the awareness in the society around you that epilepsy surgery is possible, is safe, and is beneficial. This may be in the print media, TV. You need to get to talk to doctors in IMAs to get referrals, roundtables, CMEs organized by the hospital on epilepsy, and then finally word of mouth. So when all this clicks, then only it's possible to do epilepsy surgery on a consistent basis in the private sector. So what have we done? I left Chitra in 2010, and our team's collective experience till January 22nd, 2024 is we have done nearly 465 patients of patients who have undergone epilepsy surgery. In that, 229 were pediatric epilepsy patients, adults were 236, temporal lobe surgeries were 195, and unlike the saying that temporal lobe surgery is more common, finding that in private sector is more difficult, because already there has been a trend of doing these surgeries in the national institutes, and the temporal lobe surgeries may have progressively come down. Extratemporal surgeries 270, hemispherotomies 42, motor sparing subtotal hemispherotomy 9. I'll talk a little bit more about this during the course of my presentation. Frontal lobe surgeries, one of the bugbear of epilepsy surgery is frontal lobe. It's difficult to localize, lateralize sometimes because it spreads very rapidly. And I want to show that stereo EEG, as done by Bonini, the French group, have organized frontal lobe epilepsy so nicely that by taking a good history, you are able to lateralize and localize frontal lobe epilepsy. Posterior quadrant epilepsy, parietal lobe, occipital lobe, total callosotomies. We have done about 25 stereo EEGs. This number is higher now. Awake craniotomies in 13. The advantage of doing a stereo EEG or invasive monitoring is that the extraoperative mapping you can do in a calm, collected manner rather than do an urgent brain mapping during surgery, where you walk a knife's edge between keeping the patient happy and mildly sedated and over-sedated. Hypothalamic hematoma 5 and about 20 reoperations. So I have already talked about this. Clinical, which is the most important thing which we follow in our group. Interictal EEG, MRI, neuropsych, ictal VEG, MEG, the functional imaging, and finally siege. This is the same protocol we follow that I and Dinesh Naik have learnt in Chitra. We still follow this religiously, stepwise. Not every patient goes on to this last step. As you saw, it's around 25 to 30 patients who have required invasive monitoring. Now I'll directly jump to temporal plus surgery, because temporal lobe surgery can fail. In fact, some of the early papers have shown that its cure rate is 50%, 70%. What are the reasons? Ashok mentioned about refinements in surgical technique which improve. There is also an entity called as temporal plus epilepsy, where the seizures arise from the structures surrounding the temporal lobe, the frontal operculum, the insula, the orbitofrontal cortex, which very closely mimics a temporal lobe epilepsy, and it requires a very astute clinician to pick up the red flags to say this is not temporal lobe epilepsy, it's temporal plus an epilepsy. So we go to one example. I'm showing one example in each category in the interest of finishing it early. 24-year-old, I have time now, Matthew. 24-year-old girl with plenty of red flags. Full-term normal delivery, no early insults, unprovoked seizures since age of 3, predominantly nocturnal seizures. Again, nocturnal seizures is not a feature of temporal lobe epilepsy, more of frontal, in clusters of 2 to 3. Fear, epigastric discomfort. This restlessness, again, is a red flag, severe restlessness. The MRI scan was normal. The video EEG showed this kind of spiking in the temporal lobe, and the ictal video EEG showed, apart from the left temporal, there was the parasagittal chain which showed ictal change, FZ, CZ, which means that the seizures are coming from somewhere else other than the temporal lobe. And you see the seizure semiology. This is the beginning of the seizure. She is little restless from the beginning, turning over in bed. These are not features of classical temporal lobe epilepsy. So these are the red flags I am talking about. So the odd points for temporal lobe epilepsy was no febrile seizures, early onset of unprovoked seizures, predominantly nocturnal, clustering, initially hypermotor, then hypomotor, MRI no significant changes. Ictal EEG showed more widespread spiking apart from the temporal chain. It was there in the parasagittal chain too. And the PET scan showed no specific temporal lobe hypermetabolism. It showed apart from the temporal, it showed orbitofrontal hypermetabolism. So this patient was diagnosed by Dinesh to have temporal plus epilepsy. He thought orbitofrontal epilepsy is the most likely cause of seizures in this patient. We did the invasive monitoring where we monitored. This was before our stereo EEG started. Put a mat on the temporal lobe, strips on the motor cortex, orbitofrontal cortex, subtemporal. And lo and behold, you see this beta buzz starting in the orbitofrontal cortex. You can do extraoperative mapping, reproduce the aura, reproduce the seizures. If you reproduce the seizure with less than 1 milliampere current, it means you are very close to the ictal onset zone. Whereas if you use a very higher current to produce physiological function, elicit an aura or a seizure, that means you are far away from the ictal onset zone. The another rule of invasive intracranial monitoring is the electrical activity should begin before the clinical activity. That means you are in the correct position. Your hypothesis is correct, your placement of the electrodes, mats, stereo EEG, whatever is correct, and you get electrical activity before the start of the clinical. Whereas if the clinical starts first and the electrical starts later, that means you are in a wrong place. So this is functional mapping, producing aphasia. The results of invasive monitoring showed that the seizures started in the orbitofrontal cortex, spread and settled down in the temporal lobe. So this patient underwent a temporal lobectomy, resection of orbitofrontal cortex, more than 12 years follow-up now, no seizures, off AEDs, got back the job, married and has a child. Dinesh runs a fertility center too. Many of his patients get married and have children. So the other cause for failure of temporal lobe epilepsy is insular epilepsy. So this is a 17-year-old patient, 6 months after anterotemporal lobectomy and amygdalohippocampectomy, started getting the episodes. This surgery was done at Medanta, and Atmaram, who is one of our ex-neurology residents, referred this to Dinesh Naik. This patient came with a sensory symptom in the left half of the body, not a march, followed by immediately by excessive salivation lasting for 30 seconds. How much time I'll have? So these are the red flags, which was there even before. Do I have 5 minutes more? So this sensory symptoms starting, excessive salivation, these were red flags which were there from the beginning, which were ignored, saying a temporal lobectomy may result in 70% cure, 80% cure, whatever. But lo and behold, this patient continued to get seizures. So a total insulectomy was done via the transopercular route. It's coming and going. So this is the preoperative MRI before the second surgery, a small remnant of the superior temporal gyrus with this hyperintensity in the insula is seen. And this is the PET scan showing the opercular hypermetabolism, and the post-op CT scan after the total insulectomy, and 28 months of follow-up, minor seizures, and the patient is doing well. The histopathology came as Rasmussen's. So this is an interesting case. I talked about frontal lobe seizures, Bonini, the French group classification based on stereo EEG into 4 groups, group 1, group 2, group 3, group 4. And this is a 17-year-old boy. I'll directly go to the seizures. Is this true seizure or is this functional? He was passed off as a psychiatric case for a long time. So the things I can skip.
It is a real seizure, not functional.
Are called as integrated stereotypies. Integrated stereotypies are naturalistic movements. So in the prefrontal, anterior prefrontal localization, you get this type of seizures. Gelastic, frontal gelastic seizures is an example of this. So these are stereotypical, distal stereotypy. More posterior prefrontal, you get proximal stereotypy. This looks like as if he is playing the tabla. But he can't control it, and it happens in his shop, very disruptive to his life. And he has a gelastic component. You see that he is supremely happy about it. So this is the video EEG picture, electrodecrement response. You get this frontal leads, you get this discharges, and the MRI showed this depth of sulcus dysplasia in the prefrontal region. So this was the cause for his seizures. You can get various types of stereotypy, integrated, non-integrated. What I showed was integrated stereotypy. And the patient underwent surgery, excision. Nowadays, we don't do this kind of wide resection of the gyrus. We follow the sulcus to the depth and resect, which I'll show in a case if Matthew allows me just another 5 minutes time. So this, he's doing very well post-op. So this is an example of an anterior language area FCD. Patient has this kind of seizures, vibration sense in the right arm, stiffening of both arms, occasional clonic jerking of right arm, mostly during sleep. This is the this is the video EEG. So these are elementary motor movements. So this is the most posterior localization near the motor cortex in the frontal lobe. These are called as type 1 Bonini seizures. Type 2 Bonini is non-integrated. Type 3 is integrated stereotypies. Type 4 is hypermotor with a fear component coming from the orbitofrontal and the cingulate. So we got this, this was again large depth of sulcus dysplasia. And we have this fMRI showing function at the mouth of the sulcus. We did a stereo EEG both for confirmation that the seizures are coming from the lesion and also to do brain mapping. And this is the electrode, 7-8 electrodes were used. Seizures were reproduced by stimulation. Brain mapping was done. And the patient underwent awake craniotomy in spite of this brain mapping. This is the functional map of the brain showing the function along the frontal and the temporal operculum. And this is after the excision of this the dysplasia, and this is after the excision. So operation on the posterior language area, again patient had a sensory component because this is quite posterior in the parietal operculum and in the insula. Episodes consist of the patient holding the right ear due to pain, appears frightened, crying and calling out for parents, remains responsive during the episodes. So we had a clinical formulation saying it could be coming. Initially the MRI was passed off as normal. We failed to pick up the dysplasia in the preoperative MRI, came up thinking it's MRI normal negative, and had this stereo EEG plan. This is a spontaneous event where she clutches the ear. I'll skip that. And you can see this dysplasia which was initially not picked up. This along this deep sulcus reaching up to the insula, it's here in the insula. And we did a stereo EEG because initially we had thought it was negative. Proved that the seizures are coming from a focal area of the brain. So now we do a very limited, this is the temporal lobe, this is the parietal lobe, the Sylvian fissure. So we do a very limited resection along the sulcus to reach the dysplasia. So that's it. Above, this is the Sylvian fissure, above and below. Go along the sulcus, resect the dysplasia. And this patient had no speech deficit after the surgery. So when surgery is appropriately planned, doing surgery on the eloquent area is not going to produce a long-lasting or a severe disability. This is our youngest child of hemispherotomy, 5 months old child. And these are patients with hemispherotomy. Post-op, doing well. In fact, this has one of the best results. What do you do when you have a hemispheric lesion with preserved motor cortex? So you see only the motor cortex is preserved, motor function is preserved, but the entire hemisphere is gone. So we did a subtotal motor preserving hemispherotomy. And the patient had severe psychosis before surgery with significantly improved, goes to college, hand function is good. I'll skip posterior quadrant. In hypothalamic hematomas, we started using the trans-lamina terminalis approach, contralateral, when the hematoma is situated anteriorly along the floor of the third ventricle. And in this patient, again, this patient received radiosurgery for hypothalamic hematoma in Mumbai, which failed. Then came to us, referred to us by another of the CHITRA neurologists in Nagpur. And this is the hypothalamic hematoma. This, after the lamina terminalis approach, there was a posterior residual. The anterior part was taken out, posterior residual. Did a transcallosal, interfornicial, transvelum interpositium approach. Again, there was a small, I'm cutting the story short to tell, a small residual was left behind where I found it very difficult to differentiate between the normal brain and the hematoma. This is the small residual posteriorly, and this patient underwent a RF lesioning. Hopefully this time the patient is cured. So this patient received gamma knife, had 2 surgeries and 1 RF lesioning. And the patient stuck with us at least for the surgical procedures. And this is the post-op. Sensory cortex lesion, again eloquent area.
Sir, can we conclude, sir?
I'm cutting out. We did the stereo EG, and based on the stereo EG, we did the parietal cortex RF lesioning. So a very limited lesioning was done, where it's eloquent cortex. If you cut out the motor cortex, you get hemiplegia, because the motor strip and the sensory strip act in synergy. This is a motor cortex dysplasia which went to Niemann. MEG was done, which just showed a contralateral localization. And this is the motor cortex dysplasia. Did a resection, awake craniotomy with small portion of the dysplasia and the depth of sulcus was left behind attached to the motor cortex, which led to recurrence of seizures. This is the one. And the one peculiarity of the motor cortex is the posterior bank has all the pyramidal cells and neurons. The anterior bank doesn't have so many neurons. So you can resect the anterior bank, and this dysplasia was in the anterior bank. So underwent an anterior bank resection, initially developed hemiparesis, and completely improved from the hemiparesis. So I come back to our original slide. We stand on the shoulders of our teachers who have taught us how to go around it. And we have a dedicated group of neurologists. Most of them are from CHITRA. And 2 neurosurgeons also from CHITRA, Amit Dakwaji and Rajneesh Kachra. And we have to work with passion and determination and form a nucleus of 2-3 committed professionals and wind around them in order to do epilepsy surgery consistently in the private sector. Thank you very much. Thank you for your patience.
Thank you, sir. You have shown how you can implant this epilepsy surgery from institute to private sector and small hospitals. And I think Vijay Bahule is an example in a small private setup who is doing it regularly.
Yes.
May I invite Vijay Bahule for his talk.
How much money is involved for stereo EG and all? For depth of sulcus dysplasia you told. And you
I think it will be right on my part to start without thanking Dr. Suresh Nair and his team for taking me here in 2007 as a faculty and then putting me in the epilepsy group. And I learned my epilepsy surgery, the basics from CMC Vellore where I learned, but the techniques I learned from everybody sitting here only, not anybody else. Matthew, Girish sir, Ravi Mohan Rao sir, and others. So let me go into my talk. Ishwar told me to talk on something very basics, and we have been listening to all philosophical talk and high-end talks, and many of the things went above my head. So this is, I'll be talking to you about a simple procedure or the simple techniques that I learned from CMC Vellore and from my teacher sitting here. So this is how to resect the gyral lesion. So this is something basically, this is not for big men, this is for a resident sitting at the back. So when you talk about a gyri, resection of a gyral lesion, we all have had our bitter experiences listening to the pathologist saying that the pathology is negative, it's a normal brain. So this is a very challenging problem, and still we all go through this, and I also have a lot of problems, and I thought this is something which I should put everything together and deliver it to the resident. So we can have a large abnormal gyral surface. This is very this is a straightforward scenario, and small lesion with normal gyral surface. That is what is more important here. So here we have a sensory. This is a large lesion posterior to the motor cortex. It will look like a parietal lobe mass. So, but when we went there, we saw that it was arising from a single gyri. It was arising from the sensory gyri, and the central sulcus was just anterior to that. Everyone knows which is abnormal, which is normal. So no talk on that. This is another lesion. You can see that there's a very small lesion, subcortical, at the depth of a gyri, and normally the gyrus is looking totally normal. I opened the dura, this is what I saw. We can see three gyri here. Everything looks alike. It's not abnormal. So where to go, we do not know. So let's see how we do that. So these are the challenges. They are very small, rarely. Location in the depth of the gyri, as you saw here. Surface of the gyri can be normal. Gadgets we use for localization may be ineffective. So don't think that just because we have all the gadgets with us, we'll be able to reach it. No, it can be ineffective. I'll show you what happened to me. It can end up removing normal brain, negative biopsy plus deficit. That's a worst nightmare for all of us. And persistence of seizures, again, the worst nightmare for an epilepsy surgeon. Need for resurgery, increased cost, a problem with our management and with the patient, and reduce patient satisfaction. Our management will be after us if you are in a private sector. So this is a checklist. We'll go through it towards the end of it. And radiological evaluation. This is the most important thing. As we all learned from our teachers, we said you have to be a good neuroradiologist to become a good neurosurgeon, because radiologist is not going to show you what to do in the theater. So in MRI protocol, 3 Tesla MRI is the one that I prefer in these small lesions. Epilepsy protocol, when we are dealing with epilepsy, do all standard protocols. That will help us to identify the lesion. And navigation protocol for all cases. And navigation protocol should be for the image that shows the lesion best. I repeat this, a navigation protocol should be for the image that shows the lesion best. For example, if you ask the radiology technicians to put the small slices or thin slices for navigation, they usually put it on the T1 weighted with Gado usually. So what I told my people there is, do not do that as a conventional thing. You look at the scan, and if you have any doubt, call me. And if it is diffusion, give me diffusion. If it is flare, give me diffusion so that I can use it for navigation. So DTI is done for eloquent lesions. So navigation is what you use. And we have a tumor here, and when it is close to the motor cortex, we try to do a corticospinal tract or SLF. Now, this is an important point that I would like to tell residents. Even if you have a very small lesion, always plan it like the way you do it for a DBS. So have a point of entry, have a trajectory, and have the depth of the lesion where you want to go, and then have that. Because if you do not have this, when you are operating, there is a chance that you are going to miss the lesion. You will be slipping your pointer all around on the scalp and also on the skull, and you will have difficulty. But if you have a trajectory, you will be smack on that, and you can save time. You will be on the lesion. So next is this. First, I'll show 1 or 2 cases quickly. And so this is the image of a lesion on the left superior frontal gyrus posteriorly located lesion. So we look at every anatomical aspects that would help us to localize the lesion and to reach the lesion. So look at the coronal suture. This is a lesion here. And my craniotomy is going to straddle the coronal suture more posteriorly, but I will make sure that the posterior cut is just anterior to the motor cortex, maybe 4 centimeters away from the coronal. Then I look carefully at the posterior as look for any veins. Veins are very helpful in these lesions because that will help you to localize it. So look for small veins posteriorly. Again, have a thorough study of the gyral anatomy. So this is the scalloping of the skull that you can see. There's a small cyst. This gyra is large compared to the rest, and then there's a small posterior vein. So again, sorry, it's going the other way. Okay, so this is the image of the same lesion. This gyra is abnormal. All of us can very well understand. There is playing of the vessels. The color is pale. There's a small cyst. The vein can be seen posteriorly, and this is the normal brain. This is a superior longitudinal fasciculus, another important structure, white matter tract in relation to this. The lesion was touching that. Corticospinal tract, of course, it is posterior, but I've just included that in the study. Intraoperative ultrasound. We all think that it is a very good tool, but this case I did a few weeks ago, and I couldn't get the lesion. I tried for a few minutes. There was a senior technician from the company who was there. We were unable to locate the lesion. So this failed. So I was unable to do it. Electrocorticogram. So this is another tool that will help. If you're on the abnormal area, you get spikes. If in the normal area, you don't get spikes. That's another way to look for the correct lesion. Here also, for this case, it failed because I work in Cochin. When for complicated case, I asked technicians from Trivandrum to come down, and this boy was an experienced fellow. He came. He said there was some problem with the connection. There was some problem with the grounding. So, if you have that, use it. Sometimes that can also fail. White matter stimulation at the depth of the lesion. Here, in this case, of course, it is not absolutely indicated, but just for a completion's sake, I did it. And then I'll skip because Matthew do not want. I'll skip this thing, and this is the end of resection. So the posterior vein is preserved, and look at this pia on all sides. Make sure that the subpial dissection is done properly so that we do not damage the pia of the adjacent gyri, which can affect functions. This is an important point that I would like to show, because after resection, to make sure that we are aware on the lesion, and we have to this will give us confidence to talk to our patient's relatives. So what I do is I take the pre-op image, and then a post-op CT or MRI is done, and I fuse these two on the navigation machine. So the software allows us to do it, and you can run over it and see. So here, this is the abnormal lesion here. And then you can see that you can see pneumocephalus in that region. So that makes sure that you are right in the lesion, and you can talk to the patient's relative about that. So this tumor came as low-grade glioneuronal tumor. So next is how to take a grain out of the brain. Just for the fun of it, I've put it. So this is the small lesion, child with intractable seizures. Same picture that I showed you. So here I had two large veins anterior to that. So I looked at it, and as I said, there is a trajectory that I had planned. Then this is what I saw during surgery: 3 normal gyri, and now if you cut this gyri to reach the lesion, the lesion was smack on the hand area, the omega's knuckle thing. It was sitting there, and it can produce deficits. So what we did is a transsulcal approach. We went like this, and then dissected the gyri transsulcal, and then coagulated the pia here, and then took the biopsy of it. I'll show, and then we did an intraoperative ultrasound that was very useful. Then intraoperative ECG showed frequent spikes. I make a small incision on the dura, so, and I won't make a big opening, because sometimes if it is near the motor cortex, there is a chance that the brain can prolapse and you can have problems. Even with veins rupture can happen. So I put it inside. Then I open the dura, flip open the dura, and make sure that I identify where these gyri were. So this is what we saw. I'll show this video. I'll show you, Matthew. So this is a video. This is the posterior 2 veins that we could see. I did a arachnoid dissection here, and I'm going transsulcal. Again, using navigation to make sure that we are in the ballpark. Using a micro scissors at the depth of the sulcus, we coagulated the pia, and then we started taking the biopsy. So this is the post-operative ultrasound showing that the lesion is only partially resected. Now I'll tell you why I went like that in the next case that I'm going to present. This came as focal cortical dysplasia. This is the small video of the child. There is only mild weakness of the child on the contralateral side. This immediate post-op video. So this is a very important thing that I would like to share with the residents. So this is a philosophy that I would like to follow. One small philosophy here, Ashok. You can always return and do more, but you can never return and do less. It's from Jules Hardy. And here, let's see what we did with this. This is a young sister who came to us with this lesion. She has been having it for the 4-5 years, being followed up in many centers. Recently, there was raised ICP. The size of the lesion had increased, so I decided to go in. And then this is my surgical plan. The plan was to do an awake surgery because it was in the motor cortex. Do a frozen. And see, if it is benign, I said I will not remove that lesion completely. I will do a partial excision. And if it is malignant, we will do a total excision. The idea of partial excision is to prevent permanent neurological deficit, because if it's a benign lesion, we can follow it up. And if it is total excision, they were ready to accept that. So this is what we saw. So opening, this is what I saw. This is a thick arachnoid membrane. So many a times you will not see the normal brain. You will not see the gyri even. You will see a thickened arachnoid over that. So this, I just opened the arachnoid. Again, the pia was abnormal. Did tumor fluorescence because I had a feeling that there was a downgrading of the tumor and it was becoming malignant. So I did tumor fluorescence. Again, it was not very useful. Did phase reversal, identify the central sulcus, and then did white matter stimulation. So we can look carefully for the small twitches in the leg. So frozen was sent. It came as no evidence of malignancy. So hence the surgery was stopped at partial excision. I scrubbed out, spoke to the patient's relative saying that I have stopped it, but we'll decide to reoperate if it comes out as something different. So his final histopathology was oligodendroglioma to type 2. So then we had to go in and do. So we did a radical excision later under general anesthesia. So in these cases, I always tend to tell the patients that there is a chance that I may have to go in again. The whole idea is to prevent a permanent neurological deficit, and if it is a benign lesion, we will continue following up the patient. So I get it written on the consent also, so that there is no confusion. Now these are some of the success cases I would like to say. Now this is a difficult case, 14-year-old boy with intractable seizure. This is the lesion here. So no helpful anatomic substrate for me to localize. Navigation registration was lost during the procedure. Intraoperative ultrasound again failed because I had a junior resident from radiology coming there, and she kept telling me that the lesion is still posterior. And in fact, she was actually wrong. She did not have the orientation. I also didn't have the orientation. And intraoperative ultrasound failed. I struggled for almost 3 hours. And then finally I reached the... I reached the lesion. I identified the lesion, did a partial excision. And no, there's something wrong with this. Okay. And so I went all around, anteriorly, posteriorly, and the child woke up with grade 0 power on the contralateral side. But one relieving factor was that the tone was good, indicating that and reflexes were intact on that side, indicating that it was a SMA syndrome. So luckily the child improved. And this is what's happening now. His upper limb totally improved. He's still having a deficit. I have a feeling that, and we did a post-op scan, and we showed that I had entered the motor cortex. So that is my mistake. So these things happen. So this is a checklist that I have for residents. Thorough radiological evaluation, MRI with diffusion tensor imaging whenever needed, neuronavigation, tumor fluorescence. But tumor fluorescence is not good for benign lesions. Single gyral lesions are usually benign lesions. For large tumors, you can use tumor fluorescence. Intraoperative ultrasound, you can fail. Intraoperative nerve monitoring, ECG, white matter stimulation or whatever. Awake surgery in eloquent region. Intraoperative findings. This is what we all should train during our residency. When you open it, try to identify, go through, look at each gyri, try to learn the gyri and see whether it is normal or abnormal. And if it is abnormal, learn how to differentiate that. Many a times you will have surprises like what I showed you in one of the slices. The arachnoid can be thick over it and you won't be able to see anything. And post-op imaging, always do that. That will help you to make sure that you have done a good job, or probably you have failed. So use all the gadgets available to improve accuracy and precision, as some of them can be ineffective or can fail. Educate and consent the patient that the biopsy can be negative. That is very important. Patient satisfaction is very important when you come to private hospital. Thank you.
Thank you, Biji, for an enlightening talk. Just wanted to make a point. This is one of what Biji says, that between the lines, there is something that to be noted. That is, this is a technique that has evolved from epilepsy surgery. Removal of small areas in the brain without producing any deficit. That is subpial resections. These are all these guile resections are subpial resections, where you preserve the vessels. And I just wanted to add one aspect from my experience. Eloquent cortex is extremely forgiving. Eloquent cortex is no cruel master. If you have preserved vessels and if you have not hitchhiked into the white matter, you'll hardly get a deficit. If you have lost your way vastly, will you have a problem? Lesions like AVMs, cavernomas, dysplasias, even on the eloquent, even on the language areas, give extremely good outcomes. There is no need to fear at all when you find a lesion on the eloquent cortex. Any more? Are there any more questions?
Did you use surface rendering MRI technique to match with the improv finding and MRI?
No, sir. No.
Do you think, Matthew, that surface rendering data in the MRI, that's a technique I find very useful to translate into the OT?
Yeah.
So it will be as if you have exposed the brain when you do the surface rendering.
Yeah, that's a finer level of stereotaxy. There is one more aspect I just wanted to say that we started using in CHITRA. That is, you can have a live, you can do an ultrasound on the surface, co-register it on top of the MRI, and then continue with your navigation, which will be the next higher level. I remember having learned the subpial technique from Ravi Mohan Rao sir. It was actually one of the biggest breakthroughs that I've had in my entire neurosurgical career. That is preserving the blood vessel, going under the pia, removing the cortex, and still getting a good function and excellent outcomes. Thank you, Dr. Biji.
Thank you, sir.
Okay, we have come to the end of this section.
Wait.
Thanks everybody for patient listening and for all the speakers.
Thank you, sir.
Thank you.
Now I request chairpersons to give a token of appreciation to our speakers. Now I request Dr. Malla Bhaskar Rao sir. Now I request Dr. Arivigan sir. Next, I request Ashok Pillai sir for the stage. Next, I request Ravi Mohan Rao sir to the dais. Next, I request Dr. Biju Bahalian sir. We'll have one photo of all the speakers with chairpersons. request one photo shoot, sir, with speakers, chairpersons, and with Bhattacharya, sir. Sir, for photo session.
With the speakers. Sir.
Next, I request Dr. Biju Badran, sir, HOD Medical College, and Dr. Raghavan Iyengar, sir, and Dr. Jain George, sir, to give token of appreciation to our chairpersons. I request Sunil Kumar, sir, to the dais. Next, I request Dr. Matthew Abraham, sir. Dr. Jain George, sir. Sir, I request Dr. Jain George, sir, to give token of appreciation to Sunil, sir, to Bhaskar Suryanarayan, sir.
We'll start with the next session now, that is cerebrovascular neurosurgery. To guide us through this enlightening session, we invite our esteemed moderators, Dr. Girish Menon, sir, Head Department of Neurosurgery, Manipal Hospital, Mangalore, Dr. Raja K. Kutty, sir, Professor Neurosurgery, Trivandrum Medical College, and Dr. Arun P.S., sir, Consultant Neurosurgeon from KIMS Health, Trivandrum. I request them to take their seats. Our first speaker will be Dr. Shivashankar Marajke, sir. We are pleased to have with him here, who will be sharing his expertise on topic cerebral bypass decision making in cerebral aneurysm surgery.
Yeah, so just welcome to this session, and as you would have all noticed, we are 1 hour behind schedule. So I guess we need to really accelerate, and this session we need to be in top gear.
Yes,
I've already requested the speakers to maybe curtail the time and curtail the talks, and over to you, Shivashankar.
Yes. Thank you, sir. Namaste, respected teachers, seniors, colleagues, and my dear friends. It's an honor to be here, and I thank my alma mater for Sri Chitra for making us all what we are today. So I have been asked to deliver a talk on this revascularization in cerebral aneurysms. Decision making, it's merely my experience as a practical experience. As you all know that the ideal treatment for cerebral aneurysms is to isolate the aneurysm or eliminate it from the main circulation and maintain the flow through the main vessel and even the branches. So that can be very well achieved by clipping the aneurysms. And in some of the cases where the vessels are diseased or the aneurysm is large or no good neck, we need to sacrifice the parent vessel, and in that scenario we need a bypass. So I will keep my talk strictly limited to the surgical part of treatment of these aneurysms, rather than going into endoscopic treatment that has changed the complete scenario of the way aneurysms were managed. So I thank my teachers. If I have seen further, it is by standing on the shoulder of giants the teachers who are sitting here and who have inspired and brought us to this level that after completing neurosurgery from Sri Chitra, presently I have settled in this place. It is Kolhapur, a small village 15 kilometers from Kolhapur. It is on the border of Karnataka, Maharashtra. So I'm there for the last 10 years, and we are doing a good number of cold cases as we do in Sri Chitra. And since it is in between Mumbai and Bangalore, so many patients, those who can't afford to go to bigger cities, they come to us being charitable. We're able to do a good number of vascular cases, had the operative clip around 400 aneurysms and around 50 bypasses, skull-based surgeries and endoscopic surgeries. So coming to the topic proper, as I told, the ideal treatment of aneurysm should eliminate the aneurysm and maintain the flow through the blood vessel. And we do this with clipping. And there are some cases like when the size of the aneurysm is too big, or when it is fusiform, or when it is blister aneurysm, or when it is inaccessible, mainly in petrous, lateral, cavernous segment. And when there are no discrete necks, or there are technical difficulties in clipping, we need to do trapping of the vessel, or a proximal vessel occlusion, or excision of the aneurysm, and we have to do a bypass. So this option is inferior to direct clipping because they sacrifice the parent vessel and branch vessels. So I would like to start with this case. She was a 27-year-old female who presented to us with vague headache and retrobulbar pain. And she was evaluated in one of the Central Government Institute, and this was aneurysm seen arising from the cavernous ICA and coming into the middle cranial fossa. This patient had no good ACOM or PCOM for cross circulation, and in our scenario and setup, we could not do a balloon occlusion test in our region. So looking at this big aneurysm and without any good PCOM and ACOM, so we went ahead with selection of the high flow bypass. You can see there's no, only one side A1 is there, and there are no PCOMs. So we went ahead with the high flow bypass using radial artery graft and trapping of the aneurysm. And so this is what we understand. There is a giant cavernous ICA aneurysm, poorly developed ACOM and PCOM. There was no good cross circulation, and we could not do balloon occlusion testing. So we went ahead with the ICA ligation here and even clipping just proximal to the ophthalmic segment ICA, and we did a radial artery graft, and this is the radial artery which is connected from the external carotid to the middle cerebral artery here. So this is the DHA, which shows a well functioning graft and good perfusion to the ipsilateral hemisphere. So when we encounter these complex aneurysms which we are not able to clip, so the questions what arise is when we go through the imaging, we study whether it is clippable or it is not clippable, and we need to study about the cross circulation, how is the ACOM, how is the PCOM, and any another vascular malformation, like probably there might be a persistent amyloid artery or a one side IC is occluded, and we need to study about both the vertebral arteries. So when you know that there is no good cross circulation, then we need to think about the balloon occlusion testing, and then but have marked asymmetric decrease in the hemispheric cerebral blood flow, and they have moderate risk and typically require revascularization, probably a low flow bypass. And in group 3 patients, the patients who develop numerical deficits during bone occlusion testing, definitely they require a high flow bypass. So coming to bone occlusion test, you all know that it simulates the ischemic condition caused by ICA occlusion that we are going to do once the patient tolerates. However, the test can sometimes produce false negative findings, and it can have a ischemic surgical complications can subsequently develop. In fact, delayed ischemic complications can occur in around 10% of the patients who pass the bone occlusion test with hypertensive challenges. So in addition, after ICA occlusion without revascularization, there is a hemodynamic alteration in the circle of Willis, and these hemorrhagic changes can create a conditions which form the de novo aneurysms, and or they can enlarge the asymptomatic aneurysms, exposing the patient to a risk of subarachnoid hemorrhage. So this is one case where I want to show here that when one IC is not there, then the opposite IC takes the whole blood supply to the hemisphere. This is a patient who had these 4 aneurysms, 2 in the ICA, 1 is in the clinoid and in the ophthalmic segment, and this is a ACOM aneurysm also she had, and this is a basilar top aneurysm. And there is a large PCOM and a large ACOM which were taking care of the whole circulation of the left side from the right side ICA and right side posterior circulation. So this was a pre-op CT angio which showed a SH there in the prepontine system and Sylvian fissure on the left side. The aneurysms were on the right side. And this is, you can see that the left ICA is absent, the right ICA is patent, and that is a right ICA aneurysm. There are 2 aneurysms, and there is a large PCOM which supplies the IC on the opposite side. So this is a ACOM aneurysm. The ACOM intraoperatively was equal to the size of ICA when we clipped this aneurysm. So this is what happens if the one IC is occluded. So this was a quite difficult aneurysm because it was almost more than 1 centimeter above the dorsum sellae, and it was projecting posteriorly. So we had to unlock the temporal lobe and then go posteriorly to the trans-Sylvian FTOZ approach, and we clipped basilar top and ACOM aneurysm, but the ICA's aneurysms we have not yet touched. So there are a few contraindications for bone occlusion testing, mainly when the patient's clinical condition is not allowing or reliable monitoring, because if the patient is not in a good neurological condition, the patient may not cooperate for testing, or when we cannot hypernize, mainly the conditions like when patient has a subarachnoid hemorrhage, we cannot do this bone occlusion testing. So the protocol consists of temporary blood occlusion of the ICA for around 50 minutes with continuous neurological and EEG monitoring, followed by a hypotensive challenge with assessment of cerebral blood flow using even SPECT. So SPECT images are analyzed for a asymmetrical distribution of the tracer and hypoperfusion of the ipsilateral to the bone occlusion test site and compared to the baseline. So there are risk of bone occlusion test also. 3 to 8% of the patients develop complications, many dissection, thrombosis, and even neurological deficits. It goes up to 2 to 5% of the patients, and around 0.3 to 0.5% patients have permanent deficits. So there are good chance of even false negative results with ischemic consequences when we ligate those vessels believing this test. So coming to what happens to the patients whom we the test was negative, and the patient underwent ICA occlusion, and the Roski et al. Reported that around 70% incidence of transient ischemic attacks and 17% incidence of stroke after ICA occlusion over a mean follow-up period of around 12.5 years. Oldershaw and Oris reported around 10% incidence of stroke after ICA occlusion over a mean follow-up period of around 5.2 years, which was nearly 25 times that encountered in the general population. So in contrast, Kak et al. Reported no real ischemic complications after ICA occlusion in their follow-up study. So this is the case, many would have seen it. This is, I have shown there is a quite a large aneurysm going up to the molar tooth and dissecting the whole parallel sinuses. What I want to show here is that this patient was diagnosed to have this aneurysm 8 years back, and she had gone to one of the central government institute, and this is the aneurysm we can palpate here, and she has undergone bone occlusion test also, and during procedure she failed the test, though there is a good PCOM, I don't know how. And after that, there was some time taken for recovery, and they never went back. And she had lost one vision on one side, and there was a third nerve palsy. And after 7 years, she came back to us with a loss of vision on the opposite side, and she was referred back to the Parent Institute. And because of some technical issues, the procedure was deferred and she was sent back. And unfortunately, she bled through the nose, the HBK was significant, and luckily she survived after all these things. And she came to us. And since it was a very large aneurysm and rapidly visual deterioration was there, so we went ahead with the radial artery high flow bypass. And we trapped the aneurysm between the ICA proximal to the ophthalmic origin and in the neck. And we aspirated around 10 to 15 cc of blood so that we can decompress the aneurysm and decrease the pressure on the optic now. So this is a radial artery graft what we use, and tunnel it under the skin, and we do this bypass. So cerebral blood flow measurements with Berlin occlusion test are important, and because they identify the patients who tolerate the occlusion but still require revascularization. So mainly it is group 2 patients, and the false negative rate of Berlin occlusion alone is thereby reduced by this cerebral blood flow studies. In the terms of these risk of patients in group 2 and group 2 would settle for revascularization by each approach. Yes.
Double up.
Yes. So it is a second group of patients, group 2 and 3, where we directly do a bypass that is mainly universal revascularization approach. When the cumulative risk of Berlin occlusion test, immediate ischemic complications, delayed ischemic complications, de novo aneurysm formation, and existing aneurysm enlargement are evaluated, group 1 patients are at group 1 patients are those patients who were negative for Berlin occlusion test, are at considerable risk from this treatment approach where we ligate the ICAs. In contrast, group 1 patients who are revascularized face only a surgical risk, which is around 7 to 10%. The risk of immediate and delayed ischemic complications, as well as the risk of de novo aneurysm formation and existing aneurysm enlargement, has been greatly reduced. So what are the options for donor grafts? Options for donor grafts range from in situ pedicles such as STA, hospital artery, to the high flow, intermediate flow, and low flow that I told are mainly the vein, artery, and in situ pedicles. So method for selection of such graft have been primarily based on the speculation using expected tertiary flows, mainly ACOM, PCOM patency or preoperative assessment such as Berlin occlusion test. However, the optimal revascularization strategy should be directly match the graft flow to demand on case-by-case details. So ST is a good vessel, but looking at the diameter, that might be insufficient because we need to do single anastomosis, and patency rates are very good. So these are the grafts what we take, and flow replacement is where when we measure the flow across these vessels, and this is in this scenario the pressures are measured distal and proximal to the vessel to be sacrificed, and the graft is selected as per the required flow. This is what is mean by flow replacement bypass. The concept of a flow replacement bypass utilizing a flow assisted technique using a Doppler at matching supply to demand in order to maintain adequate flow in the parent or distal branches. So the supply from in situ pedicle grafts such as hospital artery or STA is determined by measuring the cut flow and the suitability of these vessels for matching the demand determined directly. So once a bypass has been performed, the success in achieving full flow replacement is verified intra-op by measuring the flow across the graft. So I will like to conclude. The challenges in decision making for revascularization of complex aneurysms fall into two major categories, mainly the patient selection, graft selection, and verification of bypass success. In regard to patient selection, we have a selective approach which patients we select after doing a Berlin occlusion testing, and universal approach where we don't do Berlin occlusion test and take the patient directly for bypass. So in regard to graft selection, the primary goal is to adequately match supply to the demand, which requires both determining the flow demand and assessing the adequacy of potential in situ donors. So a non-selective approach where without flow measurement carries the potential for an inadequate bypass if an in situ pedicle graft is utilized, or subjecting patients for unnecessary to the additional morbidity of vein or arterial interposition grafts because we need to anastomosis here. So direct intraoperative measurement of a flow can guide the choice of flow replacement bypass graft and help us to ensure an optimal revascularization strategy. So furthermore, the adequacy and patency of graft can be immediately and quantitatively verified intraoperatively by using these Dopplers. Thank you.
Thank you,
Thank you,
Shankar. So is the take-home message that universal bypass is a better option and a safer option? Right?
Yes, because patient themselves, they have to undergo the risk involving the balloon occlusion testing.
Because it's not foolproof, balloon occlusion.
Yes,
is
because
not
there are false
foolproof,
negatives
so
available. Yes.
So the take-home advice is master the technique to do a bypass so that you don't have to take the risk of sacrificing the vessel without a balloon occlusion.
Yes.
Thanks.
We never used to have that much problem with balloon occlusion test with hypotensive talent. I don't think, I think you are overestimating the complications. It's not that high. Probably you have gone through literature.
Yes, sir.
We used to do that at CHITRA, and not many patients had problems.
The study from around 1,300 patients.
Yeah, that's true, sir. But it's again, it's a risk that you're taking because we never know after you like it. Thank you, Dr. Shivshankar.
Thank you.
Anyway, whatever when things are not things, the standard of care is BOT. Before proceeding for any revascularization, that is the standard of care.
Anyway, we won't go into the controversy, and I invite Dr. Nupur for the next session. Nupur is a master in bypass and anastomosis, and he conducts biannual workshops at NIMANS. So he will be talking on double barrel and single barrel STMC bypass and the management of cerebral aneurysms.
Thank you, respected chairpersons. It's a distinct honor and privilege to be standing here. This is a place which is a pioneer in cerebrovascular surgery, and I have learned a lot from my colleagues here and from the teachers here. The topic given to me is double barrel and single barrel STMC bypass in the management of cerebral aneurysms. Excellent talk by Dr. Shivshankar. I just want more of the younger generation to come up with this work, because what I see just discussing with Dr. Ishwar before coming here, everyone wants to do endovascular rather than spend time in training for these so-called difficult surgeries. But if you train, it's not difficult. I had a very small interaction with Professor Bhattacharya. I came as a resident for 15 days to CHITRA in 2005. I think 2005 we came here, and while we were watching an excellent AVM surgery by Professor Bhattacharya, we were standing in one corner, and while closing Dura sir made a very significant statement which I remember till now. It's been almost 19 years, sir. The statement was, a surgeon should be like a thief. He should see his way out very well before entering a house. I think people will agree with that. This is Dr. Bhattacharya's statement. And the conclusion of my talk is also this. A surgeon has to see his way out before entering a house. House maybe here can be replaced by an aneurysm also. So I have just 4 cases here, and then I have a video, so you can stop me whenever you want. The first case is a 42-year-old male with a tuberculum cella meningioma and a bilateral complex MCA aneurysms. 75 to 80% of my cases of aneurysm in which I have done bypass, my partner in crime is Dr. Vikas, who is a very esteemed alumnus of this place. We did both of all these surgeries together. This patient actually came to him with blindness, tuberculum cella meningioma. He operated this tumor. Dr. Vikas operated this tumor for a tuberculum cella meningioma on the right side first. Both the aneurysms were complex and asymptomatic, means unruptured. So these are the aneurysms. Do I have a pointer here? Okay. No, that doesn't work. Is it coming? Okay, this August gathering doesn't need that. Yeah. So we can see the aneurysms here on the right side. So we attacked the aneurysm on the right side first. Although it seems simple, but this was very wide necked and one of the most toughest aneurysm, the texture wise, what we have seen. And despite clipping attempts, this aneurysm could not be obliterated. The left side aneurysm, as you see, is also a broad neck, and we see 3 large branches coming out of the aneurysm. And the challenge was to save all these 3 branches. And knowing from the right side, we knew that these aneurysm is very very hard and complex. So on the right side, that's what we have done. As you can see, a high flow bypass going to the ICA, and then we had to coil this aneurysm. So again, teamwork is very important, both amongst us as well as with our radiology colleagues or the intervention guys. So we have done this. But my topic of today is on the left side. So from the left side, we did a 2-stage surgery. The first stage was a double barrel bypass on the left side. That's where I need a pointer. So, but anyway, you can see here. I can show you. This is the large frontal branch. This is in the frontal area, and this is another parietal branch of the STA supplying the. Both are supplying parts of MC circulation. Now, obviously, this is not supplying a large part because the demand is not there. A day or two later, Dr. Vikas went inside and opened the fissure and did a very good job with this aneurysm. He has with the multiple clips and with the protection which the bypass is providing you, you take out the temporary clipping duration out of the picture. If your bypass is there, thank you so much. Yes, so now you see that the bypass is already supplying a bigger area, and the aneurysm is very nicely clipped here, which we've seen much better in this. And you can see that that he has been able to manage to preserve all the 3 branches, this 1, 2, and the lower branch. So it gives you insurance. It gives you that it takes the temporary clipping duration time out of the picture and gives you a lot of confidence to go ahead and to put clips on every vessel, every outgoing vessel, and then do the clipping job. Open up the aneurysm and so take home messages. This was an example of, I would call it an insurance bypass. To go ahead and do the attack the aneurysm confidently. The importance of EC injection, though I have not shown you the EC injection, you should stress whenever your intervention team is doing the angiogram, they should give you a EC injection because you need to see you have 2 branches of STA available or not. There is a high degree of variation in the STA. Some have only parietal branch, some have only frontal branch. Usually both parietal branches will be there, but you need to check it beforehand. Insurance of distal circulation while you completely trap the aneurysm is of immense importance. Bypass and clipping need not be in the same sitting. We always feel that once we have done the bypass, we should immediately attack the aneurysm. What we have learned over the years is that we can take our time, but of course, we have to be very good with our technique. And importance of teamwork, as highlighted in the previous, is this case. The second case is full of ups and highs and lows. It's a young 23-year-old girl with blurred vision. And this is her aneurysm. It's a giant supraclinoid IC aneurysm on the right side. So this is our left injection. You see even the left A1 is also, there's a mass effect on that. BTO tolerated, yes, as we were discussing, Shivshankar was discussing. But you can see there's a significant delay here on the capillary circulation on the left side as well as compared to the right side. There's significant delay. So there's no doubt, is a young patient. Absolutely, despite passing BTO, patient needs supplement to the perfusion here. So what do we do here? This is the posterior circulation. So we did a right STMCA double barrel bypass, and we planned for followed by ICA ligation. Now Dr. Vikas is very comfortable now with his transcavernous approach, and after I did that right STMC double barrel bypass, he joined us. And he exposed the whole of we tried to expose the whole aneurysm, including the cavernous ICA in this patient. Unfortunately, despite discussing in much detail with the radiologist, we could not figure out where exactly the anterior choroidal artery was arising from the circulation, from the ICA. So at one point of time, we decided, it was late in the evening, around 7 o'clock, we decided that I think let's skip this and let's ligate the IC in the neck. With that, we handed over to our senior resident and we left out OT. 2 days later, we kept the patient in the ICU for a long time, but 2 days later, we had a surprise. And the august audience can clearly say that instead of the ICA, our resident, I'm very proud of my residents, they do a great job. But sometimes, see, our resident has ligated the ECA. So I was, like this slide, I was blank. I was totally blank. I don't know what to do. I mean, you see, as you know, hours of hard work from morning till evening, and one mistake in the end can destroy everything. But there are more surprises to follow. And then we both went and saw this, that ECA has been ligated. But then you see the other side ECA, and again I highlight the importance of ECA injection. Now, there was no reason for the radiologist to do the ECA injection on that side in a check angiogram. But they did it, and see what we see here. See, this is the ECA injection on the other side, and if you see carefully, there are some collaterals through the skin and muscles of the neck, in the neck here, and they are coming here, and then somehow forming the ECA to some extent, and through that formation of the ECA, both the bypasses are filling, if you see carefully, from the opposite ECA. I've never seen anything like this. But Mother Nature is there to help you, and the patient is fine. We knew patient will be fine because the BTO was, patient had tolerated the BTO, but this was totally unacceptable. I never expected this. But see how the other side ECA has helped us by reformation of the STA here, and to some extent the bypass is still working. So, do you think if I open up the ECA which is already ligated, will it open up? So you all can think about that question in your mind, but we did try that. We opened up the ECA, and ECA did open up, to our surprise. This is a DSA done 2 or 3 days after we opened the ECA, and on table also we could see with Doppler and other things that ECA did open up. Basically, ECA is a large vessel, and some amount of intimal injury is probably tolerated, but I hope this doesn't happen again to any of us here. The ICA has been successfully ligated now, and you are not seeing the aneurysm now. So ECA ligature was removed carefully, ICA identified properly and ligated. And finally, you see that the right ECA injection now is filling almost completely the MCA circulation, both the double barrels. This is one branch of STA, this is the other branch of STA, and it has almost taken over completely the MCA circulation. Of course, after a lot of hiccups. So we have done the ICA ligation now, and the aneurysm is not filling now. So this patient was discharged in a stable condition with no fresh deficit. So there's nothing like an easy and difficult step. I think I take the responsibility for what happened, and probably we should have been there when the ligation was happening, and we should have been there to guide the resident. And so every step is important. In such surgeries, you cannot neglect even a single step. I would say this is also an example of good flow augmentation. This is not flow replacement, because still the other side is also supplying, and this is also an example of good flow augmentation. But
Why did you do angiogram that night?
no, we didn't do that night, sir. In fact, this is 2 days later. We never expected this.
Hima called you after 2 days.
2 days. Because we routinely we'll let ICU, let us ventilate and all that. So after 2 days that was.
That's also started going to the opposite.
Yeah. And it was good of us to do the left EC injection. So otherwise you wouldn't have never found out this. So quickly, 2 more cases. 34-year-old female present with drooping of left eyelid for 2 years, and she has, as you can see here, she has bilateral cavernous IC aneurysms. The left is bigger, and she's symptomatic for that side. And interestingly, she doesn't have a A1 here. So classical teaching or classical thinking, logical thinking says that this patient, there's no point doing a BTO here, because there's no A1 here. So this was one of my first cases in which I was doing bypasses for aneurysms. And in fact, I did the left STMC bypass. Then I called the radiologist. I think that day also Hima was there. I called them to the inside the OT with our regular CM. I made them to do the BTO on table after waking up the patient, whether this STMC is sufficient on table to do, and then only when they did the BTO on table after the bypass, I went ahead and ligated the ICA. And these are intraop DSA images. This shows that the bypass was patent, and in fact the MCA was filling well, and even till the flow was coming till the ICA. So for those who think that STMC bypass cannot be used as flow replacement, I think we need to rethink about it. So this was the BTO on table, and this patient again did well. But my question is, what to do on the other side? She is still asymptomatic. She is refusing to get surgery done for the other side. But let's see. So it can replace flow. Question remains, what will you do on the other side? Because that side A1 is also dominant and supplying both A2s. But whenever she comes, we'll see. Quickly, last case. This is a ruptured case. A patient who has come with ruptured aneurysm. As you can see, the IC is deceased. Right from here, right to the cavernous IC looks deceased. And the disease segment is continuing to the supraclinoid ICA, and this is a broad necked aneurysm with a small tip here. So again, STMC bypass, this, as all of us know, these aneurysms have very high chance of rupture on table. So why don't we do a bypass first and then attack the aneurysm? Like an insurance bypass. So insurance STMC bypass written with clipping. This is the bypass done, which is patent after surgery, and this is the, and we were able to clip the aneurysm to a large extent. So this was the aneurysm, this is the post-op clipping. So this patient also did well. So insurance bypass is another example of insurance bypass, which is a good strategy while dealing with diseased vessels and also blister aneurysms. So there's not much literature actually. This is probably one of the large series. This is 44 patients. This group is from US, Houston. And the 44, but only two aneurysms with the double barrel bypass. There's another series in which they have 12 cases of aneurysm in which they have used STMCA double barrel bypass as a flow replacement. So whether STMCA double barrel is equivalent to high flow bypass, it's a matter of controversy. And of course, we cannot, every case is different. So with that, if I have time, I'll quickly show a video. Exactly, do I have 5 minutes? Especially for the young people in the audience, the technical pearls. So, Dr. Ninad, who is a product of this place, has helped me significantly in making up this video. And so, I just go a little. So we have a different technique of doing arteriotomy. So that's what the first thing which I want you to see. So this is a slightly less than 1 millimeter artery appearing. This is in a highly magnified view under microscope. We use a suture. Initially we used to use one suture. Now we have come to 2 sutures. This is another suture just next to it. We did this just slightly to increase the length of the arteriotomy. So our arteriotomy is an excisional type of arteriotomy in contrast to the incisional type, one cut, linear cut, which is done most popularly. So now these sutures will be used to handle the vessel rather than directly handling the vessel. This is the first cut. This is the second cut using the first suture. And then this is the third cut. And while previously we used to take the fourth cut, but now we use this as a flap and just suture it to the neighboring pia and use this to keep the vessel open and the lumen, both the edges of the arteriotomy wider apart. So this suture is taken in the flap. We call this a flap retraction suture. This technique has been published. And you see how this flap, once tied to the pia, will keep your arteriotomy open. The next important step is to match your STA to your this arteriotomy opening. And I have been asked whether very small vessels you can do this technique, and yes, you can do it. I showed you this is a less than 1 millimeter artery. Now you're ready for the suturing. This is your heel suture. It'll take 5 minutes. This is your toe. These are Tenno sutures. So the arteriotomy is open for you because of that suture and the way you have done it. Its arteriotomy stays open for you. You don't have to struggle to find the edge of the MCA most of the times. And your MCA handling is very much reduced. That's what I feel. And we use only 2 throws. We don't use the 3rd throw as classically described. Only 2 throws is enough for a microvascular anastomosis. And we have this concept also we have published extensively. So now you can see both the edges are seen very clearly. The other interesting thing is we don't use any dye. As you can see, we are using a black background here, and that is enough to give us a very good contrast. We are not using any dye on the MCA. On the STA, yes, you can see the dye. So once this side is done, now we go to the flap side, and we should see how we handle this flap. You cannot try these techniques directly, and you have to train yourself in the lab and try to do these things in the lab. Then only we should try these things. And as you see here, we are not handling the MCA at all. The only thing handling the MCA is the tip of the needle. That's all. Now we are going to cut that flap. This is the 4th cut. And this tissue is then sent for histopathology. So now that's what the point I want to make. There is very minimal handling of the MCA, and that is the one big advantage of, in addition to able to almost prevent the cross bites. So that's it. We do, then everything is standard. Once you have done, I put a papaverine cotton for 1 minute and wait, and then remove the clamps. Finally, the STA clamp is removed. It's a little loose, which will settle with some wash. This is the, yes, this is the ICG, and that's it. Thank you, sir. No, so this technique was first perfected in the animals. So we did close to almost now 200 surgeries in the lab in the rats. All the rats were opened after 2 weeks, and we checked the delayed patency. So we did not find any problem in that sort.
Thank you, Nupur. Exquisite display of surgical techniques and It's so refreshing because especially in an era where things are moving from surgical to non-surgical management of almost everything, it's very refreshing and encouraging to see excellent surgical techniques. Again, I think we'll skip questions and move on to the third topic by Dr. Jayanand, who is another master of anastomosis and cerebral revascularization surgeries, and he will be talking on rationale of bypass surgery for cerebral aneurysms.
Yeah, respected chairpersons and dear colleagues, it's really a very proud day for me to present this topic in front of you because today I'm presenting it in front of Professor R.N. Bhattacharya, who is my mentor and my teacher, and my baby steps in neurosurgery were taken as a junior resident with Professor Bhattacharya at the chair. And also my respects to the teachers who have molded me in my career, Professor Suresh Nair, Dr. Girish Menon, Dr. Matthew Abraham, Professor Ravi Mohan Rao, Dr. Ishwar. So, is there some problem with the presentation? It's not going into full screen mode. Yeah, okay. Is there an issue? Yeah, okay, done. Fine. Okay. So, two talks already have stirred up a lot of questions on the bypass strategies. In fact, Dr. Nupur is also my teacher. I have attended his beautiful programs at NIMANS, Bangalore, where he trains on animals for bypass and anastomosis procedures. So this will be the basic cerebrovascular anatomy that will be taking you through. So this is a schematic diagram of the vasculature that I'll be using for my presentation. So basically I would like to classify it into a large tertiary flow replacement versus flow augmentation, maybe a small tertiary replacement, and also some flow modulation techniques. So first let me go through large tertiary procedures, that is mainly for flow replacement and flow augmentation, as previously described by the two speakers. The balloon occlusion test and the cross flow will determine whether you really need to do a bypass procedure and what type of bypass procedure is required. So here you have a cavernous IC aneurysm, and if there is good cross flow across the ACOM and the PCOM, then probably you can just get away with a low flow bypass, maybe a double barrel bypass, and in some situations a single barrel bypass also. But if there is no cross flow, a double barrel bypass, whether it will be sufficient or whether we really need to go in for a high flow bypass, is $1 million question. Now this is a cavernous IC aneurysm, and for which the strategy, many strategies have evolved over time. There were times when people used to ligate the common carotid artery so that some reversal of flow occurs through the ECA into the ICA, and this becomes a low flow system leading to regression of the aneurysm. Even a proximal ligation of the ICA may suffice in certain situations if cross flow is good enough to sustain the brain perfusion. And in this case of cavernous IC aneurysm, we did a double barrel STMC bypass, and this was sufficient for the management of this case. And certain situations where cross flow was insufficient, say for example this cavernous IC aneurysm, we did a high flow radial artery graft between the external carotid artery and the MCA, and this sustained the perfusion. In certain situations, we may go in for insurance bypass so that a prolonged temporary clipping on the ICA may be obviated, and the risk of developing an infarct in the recipient artery is reduced by doing an insurance bypass. So you can do a double barrel STMC bypass, as in this case of ophthalmic artery aneurysm. We have done the double barrel bypass here, and then a prolonged temporary clipping and was required, and finally the aneurysm was reconstructed with multiple clips here, and the STMC bypass was mostly an insurance procedure in this case. Now here we have a large aneurysm of the M1 segment. You can see the size of the aneurysm is actually relatively small, but there is a major thrombosed component here which is not filling, and is sitting bang in the middle of the M1 segment. So there is and it's a perforated region, so it's very difficult to clip it safely. So this was a strategy we adopted. We did a double barrel or triple barrel bypass in this case because we had two branches of the parietal STA which were used for anastomosis, and then we decided to trap the M1 between the using clips between the aneurysms. Okay, so Here is it. We have two parietal branches of the STA here, P1 and P2, and this is the frontal STA branch anastomosed. And then we trapped the aneurysm. This is the M1 proximal to the aneurysm, and the M1 distal to the aneurysm is here, and the second clip has been applied here. And this was the post-op angiogram. You can see the STMC bypass working well there, as well as the aneurysm having been eliminated from the circulation. We also did this for some cervical IC aneurysms. This was a young boy, going boy who presented with a large swelling in the neck, and it was a ICA pseudoaneurysm in the neck. We did a double barrel STMC bypass, and it was sufficient. We had other cases, Petrus ICA pseudoaneurysm, and this also sufficed with a double barrel bypass. And this was a pseudoaneurysm that failed multiple attempts at stenting across this segment. This patient had long-standing diabetes mellitus, and pseudoaneurysm had developed in the Petrus ICA following osteomyelitis. And in this case, this patient, upon curiosity, we decided to do a perfusion scan to see if the STMC bypass was actually sufficient to perfuse the brain, and we noticed this perfusion deficit. This patient was asymptomatic. But the next patient was not so lucky. It's a large ICA aneurysm. You can see the extent of the aneurysm here, large thrombosed component, and a moderate sized flow component, which is only seen here. So we did a double barrel STMC bypass here. The reason why we didn't go for clipping was the posterior extent of the aneurysm was so well back posteriorly that it was difficult to dissect the aneurysm off from the perforator. So we decided to go for a no-touch technique. So this is the flow component alone seen on the DSA. And we did a double barrel STMC bypass and ligated the ICA. And we found that there is a perfusion deficit, and this patient was symptomatic in the sense that he started developing drop attacks, and we attributed those drop attacks to this perfusion deficit, and we convinced the patient probably an extra bypass will help him, and we did an occipital artery to MCA bypass, but that failed. You can see there is no flow here, and this patient continues to remain under follow-up, and his perfusion scans after follow-up for 1 or 2 years still continue to show the perfusion deficit. So rightly said, the collateral circulation will decide whether you actually need to do a double barrel bypass or go in for a high flow bypass. Now this was a giant supraclinoid IC aneurysm, a very gruesome looking aneurysm, and in this case we did a triple barrel bypass. 2 of the STA branches were used to bypass in the perisylvian region, and 1 occipital artery was used to anastomose in the posterior aspect of the MCA circulation. And we ligated the ICA subsequently, and you can see all 3 barrels functioning well post-op. You can see the occipital artery also perfusing the brain here, over here. So this patient went without any problems. He didn't have any perfusion deficit here. So for small tertiary replacements, we go in for single barrel anastomosis in most situations, depending on the location of the aneurysm. You can have aneurysms in the bifurcation or M2 segments. And some of these aneurysms that have been tackled with bypass, this is a fusiform aneurysm involving one of the M2 segments. We did a single barrel STA-MCA bypass distal to the aneurysm and then excised the aneurysm between clips. So these are the intraoperative pictures where the STA has been harvested and the anastomosis has been performed distal to the aneurysm. You can see the aneurysm over here, which was excised. This is post-excision scenario, the clip at the stump of the vessel. Now this is the pre-op scan of the same picture. You can see the aneurysm. The post-op, you can see the STA-MCA bypass functioning distal to the aneurysm. These are other pictures of post-MCA bifurcation. Giant aneurysm is a cirrhoid aneurysm. It's a large flow component which is appearing fusiform, but actually the aneurysm is much larger than what is seen in the picture here. It's a huge thrombosed component. And again, we did a STA-MCA distal to the aneurysm, and we just decompressed the aneurysm a little, and this was sufficient for the management. You can see the clip applied proximal to the aneurysm here in the M2. So this is M1 fusiform aneurysm. You can see the cirrhoid nature of the aneurysm. It's very difficult to clip or wrap the aneurysm, and even endovascular measures can fail in this. So here it is. We have done a STA-MCA bypass and a proximal clip, a clip proximal to the aneurysm, and that is sufficient to manage this case. The perfusion was good distally. This was a 10-year-old boy with an aneurysm involving the MCA bifurcation. You can see both the M2 branches taking off from the aneurysm itself. And we have done a STA-MCA bypass, double barrel, addressing both the M2 branches, and trapped and excised the aneurysm. This is a M2 segment aneurysm again. We have done a STMC single barrel bypass distal to the aneurysm and trapped and excised the aneurysm. This was an interesting case, a distal anterior cerebral artery fusiform aneurysm, and in this case we planned for a piggyback. Parietal branch of the ST was connected to the end of the frontal branch and brought into the intrahemispheric fissure, and this supplied the callosal-marginal artery distal to the aneurysm, and the aneurysm was excised between clips. Maybe for lack of time I will skip the video, and this is the post-op angiogram. You can see the STA, the augmented length of the STA reaching the intrahemispheric fissure and supplying the anterior circulation here. We did one more case just like that. It was a post-traumatic dissecting aneurysm involving the DACA. We did a long extended STA bypass into the callosal-marginal and excised the aneurysm. For large tertiary revascularization, sometimes we have gone in for flow modification or flow reversal. This was a giant ICA terminus aneurysm. You can see that the ICA is ending in the aneurysm, and subsequent to that you can see the MCS filling but not the ACA. So it's a terminus aneurysm, and this is not a suitable case for endovascular management. And in this case what we did was we did a procedure described by Salim Abdul Rauf, the internal maxillary to MCA bypass using a radial artery graft. You can see the graft here, and you can see the distal anastomosis here, and the aneurysm got reduced in size, probably because of induced thrombosis, because we reversed the flow into the aneurysm. And post-operatively we did a analysis of the flow. This was the pre-op angiogram, and we subjected this to computational fluid dynamics, and you can see the flow within the aneurysm. When we reverse the flow, you can see that the flow into the aneurysm is actually much reduced. And post-surgery, 3 months later, when we did the angiogram, we extracted those images as well and did this analysis to see that flow is much more streamlined. Majority of the aneurysm flow component is actually thrombosed. And these are simulation pictures of the case scenario. You can see the flow component, the inlet and the outlet, and to what extent the thrombosis is occurring in the post-op scenario is very well evident here. And you can see the hemodynamic parameters of computational fluid dynamics showing that the oscillatory shear index and the relative residence time of the blood within the aneurysm is actually much greater in the post-op scenario, stating that there could be a lot of stagnation within the aneurysm. But it always takes a non-objective judgment to decide whether this will work or not, because in one subsequent case of a PCOM aneurysm, large PCOM aneurysm, we did a double barrel STMC bypass and then did a proximal ICA ligation, but this failed to cause any change in the PCOM aneurysm. This is the last case, a middle cerebral artery aneurysm, a fusiform aneurysm. We opened the Sylvian fissure, did a double barrel STMC bypass distal to the aneurysm. We examined the area of the aneurysm to see if there was any way we can manage this. There is no way you can clip, so we just coiled this because it was the region of the perforators. A lot of perforators were arising from this aneurysm, and hence we just wrapped the aneurysm and came back. But this patient continues to remain on follow-up. Follow-up angiograms continue to show that the aneurysm is still remaining stable. Thank you very much for your patient listening.
Thank you, Janand. So can we summarize that for M1 and bifurcation aneurysms, you do a double barrel, and distal to bifurcation, we do single?
I think the basic thing is depending on what territory you need to perfuse. If you are going to sacrifice the ICA, it means that you are going to perfuse a large area and means that you need more flow. Either you do a multi-barrel STA MCA bypass, or you do a intermediate or high flow bypass like IMAX to the MCA, or a external carotid artery to the MCA bypass using a radial artery or saphenous vein graft. But between the M1 and M2, it is always a judgment whether how much of this territory needs to be addressed. M1 and M2, you may need to just perfuse both the M2 branches. That may suffice with just one STA to each of these M2 branches. Okay. So large territory, maybe you need a triple barrel bypass if you are doing a small anastomosis, or a high flow bypass. But whatever said, I think more distal it is in the circulation, single barrel, more proximal, multi-barrel or high flow.
Thank you, Janand. I can already see some hectic activities in the background. I think the next laptop for the next presentation is already getting ready. So we'll summarize and conclude this session. Thanks to all the three speakers and my co-chairs. Arun and Raja, you want to make some concluding remarks?
Thank you, Nubur sir, Dr. Shivashankar, Dr. Jan for excellent case scenarios and clinical videos, nicely illustrated.
Well, we had a great learning session today. We learned a lot. As everybody pointed out, that bypass is a skill that has to be learned. There is no consensus like the authentic text what to follow for a bypass. And the chairman, as the chairman of the CNS education, we have launched our first book, which is the bypass manual for youngsters, which will be launching in Bulgaria for the World Neurosurgery this October. So it will be freely available on the internet as an open resource. So we all welcome you to read it. There are around 13 to 14 chapters with world-renowned experts in it. So thank you very much.
Now I request chairperson to felicitate the speakers. I request Dr. Shivashankar Marazaki sir to the stage. Next I request Dr. Nupur. Next I request Dr. Jaina.
Three, four more.
Thank you, sir. To felicitate the chairpersons, I request Dr. N.I. Kurian, sir, Amala Hospital, Tirchur.
N.I. Kurian,
Dr. Devnath Chakraborty, sir, to the stage. And Dr. Muralidhar Paisar from Manipal Hospital. Before we move on to the next session, we'll have a short talk on neurovascular, introduction to neurovascular neurosurgical agents in microscopes by Carl Jace, to be presented by Dr. Gautam, adult consultant, CHITRA Neurosurgery.
From the organizing committee, we thank Carl Jace for the support to this excellent academic program and felicitation program that is going to happen tomorrow. And this I will make it short because we are already running behind the time. And this is regarding two adjuncts which have been added to their prestigious Kinovo, which is a very good adjuncts in the routine microsurgical era. So to this Kinovo, they have added a new software called Flow 800, where to this, as you see on the left side, that's a routine ICG induced infrared
image that we see regularly. And on the right side, we can see the new O800 software. Using this software, we can see that colorful, color-coded artery and vein, which can be nicely delineated with this software. Where the same thing is in relation to the time and blood flow. This gives an objective assessment, which gives as a semi-quantitative assessment of the blood flow in these vessels. So this can be used in aneurysm bypass to see the patency of the vessels, and also in AVM surgeries, where in other vascular malformation you can differentiate between different artery, vein, and the arterialized veins can be differentiated in a step-by-step manner while you are dissecting through the AVMs. And this software has different mapping techniques, where namely delay mapping, intensity mapping, speed mapping, and diagrammatic mapping, where different aspects of the flow related things you can assess during these stages. Delay mapping is nothing but this is an information about time when the fluorescent signal has reached the vessel. That means the vessel which has received the fluorescence at the first will be bright red, and the last receiving vessel will be blue yellow. For example, in a vascular malformation, the vessel which is receiving at the earliest will be artery, which is red coded, and whereas normal vein look like a blue, and whereas this arterialized veins will range from orange to yellow based upon the arterialization or receiving of the fluorescence. So you can see the delay mapping can be used in this bypass, where in STIMCA bypass, you can see this is the normal caliber and M4, normal caliber M4 seen on the cortical surface, where after the bypass, this is the STA here, and the bypass proximal and distal aspects of the distal aspects in relation to the graft, where you can see this graft has been already thrombosed because of the lack of flow. You can see there is a blue colored coded, and the intensity of the fluorescein has been reduced in the distal aspect of the M4. And this is regarding the intensity mapping. Intensity mapping is nothing but the total amount of the fluorescein in a whole of the area which has been under the infrared radiation. So you will come to at the end of the day, at the end of the image, the amount of fluorescein that has been concentrated in an area. Based upon the different signal intensities will give rise to signal color coded. So at the end, the intensity with high fluorescein will be coded as red, whereas the low in fluorescein accumulation will give rise to blue colored areas. The same thing, the previous bypass image where that graft has been thrombosed, you can see there is no flow which is located by in the marked by white arrow, and the intensity is reduced in the distal aspect of the branches arising from the dome. This is a micro inspection tool from this industry, where they have introduced a cable which can be directly connected to the microscope. It's an endoscope getting connected to the microscope directly, where you can pass your endoscope or instrument tip into the nucleus corners, which is having a handle with, as you can see, handle with long shaft with, and at the end you will have this shaft is of 3.6 mm diameter, and with at the tip you will have illumination with 45-degree angled scope, which can be passed and see the all around the corners of the aneurysmal clipped aneurysm. And I would like to, sorry, you have to bear with me, I am not able to fasten this. The same thing which has been shown, the I see bifurcation aneurysm, that after clipping you are looking at the different aspects of the different angles of the clipped aneurysm, where you can see that perforators have been spared from the clipping. In the other way, and in the inside you can see the microscopic view which has been in the inside. Thank you.
Thank you, sir. We now proceed to the final session of the day, dedicated to the complex and fascinating realm of spine surgery. It is our pleasure to invite our esteemed moderator for the session, Dr. Sajesh Menon sir, HOD, Amrita Institute, Kochi; Dr. Ajit R. Nair sir, Consultant Neurosurgery, KIMS, Trivandrum; and Dr. Jyotish S. sir, Professor, Medical College, Trivandrum. I request them to take the stage. I now request our first speaker, Dr. Ramesh Chandra Varmula sir, HOD SVIMC Tirupati, to talk on complications avoidance in OLF.
Good evening. I would like to thank Dr. Krishna Kumar and his team for having me here. So I will be discussing about OLIF, oblique lumbar interbody fusion, also known as the anterior to psoas approach. So defining minimally invasive spine surgery. The main definition, basic definition is getting with less collateral damage, tissue damage, without differentiating in the intended surgical goal. So you get the goal but without having any collateral damage. So when you see spondylolisthesis and all various aspects of MIS for spondylolisthesis, so many options are available. So we have minimally invasive P-leaf, T-leaf, D-leaf and A-leaf. And one more approach is the anterior to the psoas approach. So I will be discussing about anterior to psoas approach and why in the true sense it's a minimally invasive approach, because one is there is a preservation of the anatomy, there is indirect decompression without disturbing the dural architecture, then biomechanical stability because we use a larger construct, and deformity correction. So what is the concept for anterior or lateral approaches? Why you have to go lateral? So biomechanics of lateral interbody spacers, going wider for going stiffer. So they have compared in cadaver studies. The specimens were subjected to multidirectional non-destructive flexibility tests, and they have found that the best is by using a 26 mm XLIF cage, the movement was the minimum. So the major advantages of anterior and the lateral approaches are a larger interbody, torsional stability, lesser subsidence, high fusion rate, and no dural retractions. So coming to the anatomy, so this is the D-lift trajectory, this is the O-lift trajectory, and this is the A-lift trajectory. So this is one of our patients where we took an MRI in a lateral position. So in true sense, if it is minimally invasive, there is a corridor. Because of the gravity, the whole peritoneal content falls down due to gravity. So you have a corridor where you can directly reach only by splitting the external anterior abdominal wall muscles. You can directly reach the psoas, the area anterior to the psoas. And both the cadaver studies and the radiological studies have proven there is a corridor from L2 to L5, and in L5S1 that is in between the major vessels, but L2 to L5 the there is a 10 mm of minimum 10 mm of corridor between the psoas and the great vessels, and by retracting like how you do an ACDF, where you retract the longus a little bit, but with retracting the anterior border of the psoas, which is devoid of any lumbar plexus, we get even 100 or roughly around 150 to 160% increase in the corridor. So this is the dissection we see. So only two things we cut: the skin and the fascia or the external oblique. So first thing is we split the muscle, then you go underneath the anterior abdominal wall, reach the quadratus lumborum, move your finger over the quadratus lumborum, reach the transverse process, then roll your finger over the psoas to reach the gap between the anterior the psoas muscle and the great vessels. So these are the external oblique with the fascia, external oblique splitting, the internal oblique comes, the internal oblique is split, then the transverse abdominis comes, you split the transverse abdominis, there is a transverse fascia with the retroperitoneum, then you reach the psoas. So again, comparing the A leaf and O leaf and D leaf, what we have seen that the anterior to the psoas approach has lesser vascular complications compared to A leaf, and lesser neurological complications compared to D leaf or lateral leaf, where you need to go through the plexus. So the setup, you need a microscope, you need a dedicated retractor system, and a good imaging system, and this is the wide base cage we use, and this is the setup which looks. So coming to the procedure per se, so first is the incision marking, then the placement of the retractor with the pin, then disc preparation, then breaking the annulus, opposite annulus, then trial, cage insertion, and then a posterior fixation that could be either a cortical bone trajectory screws or a pedicle screws. Now indication, so basically what is the concept in anterior and lateral approaches? The main concept is indirect decompression. So what does it do? So because of the degeneration of the disc and the settling of the facets, you can see here there is the canal stenosis here, but basically that is more of due to the buckling of the ligamentum flavum. So what happens is, as the disc height is reduced, the space between the two facets joints comes down, and there is a buckling of the ligamentum flavum. Basically it's not an hypertrophy, it's buckling. So once you distract, the buckling settles itself. So you need not do any procedure from the back. So it is this is what is called an indirect decompression. So because of this indirect decompression of the spinal canal, they have found that around 30% increase in the cross-sectional area and 60 to 80% increase in the height after O-leaf. And O-leaf and the anterior to psoas approaches and the lateral approaches are now a game changer, especially in deformity surgeries, because in deformity surgeries it elevates the needs of Ponti's osteotomies and pedicle subtraction osteotomies. Now PSOs has been there since 3 decades, but even after 3 decades the complication rates are the same. So it is now a time where these will replace PSOs. And obviously because of the huge large surface area, they expedite the high fusion rates. Now case selection. Very important thing for a beginner to start is the patient, there should be a good corridor, that is the gap between the great vessels and the psoas muscle, and disc height loss should be there little bit, not much. Foraminal stenosis to start with, and the segment where you are operating should be mobile, low grade listhesis, and the bone quality should be good. Now there are the contraindication where you should not do. There is no corridor, obviously, where a previous retroperitoneal surgery has been done, where the disc is collapsed. And 2 things where indirect decompression doesn't occur, means all the facets are ankylosed, the disc is completely collapsed, and there is almost fused, bridging osteophytes are already formed. So here the process of indirect decompression doesn't work here, doesn't happen. Even if you put so much force, it won't open up. And there is a chronic disease wherein the ALL has also shortened. So in these cases you cannot open up the disc space. That is one indication, that there is one contraindication. The other is, even if you do indirect decompression, it won't help the patient. In where the stenosis is not because of the indirect decompression, because of the buckling. The patient's symptoms are due to something else, that is subarticular stenosis, and where the foraminal stenosis is not craniocaudal, but it is anteroposterior, like the tip of the SAP is coming into the foramen. All these cases, we can't open up the foramen, and this won't help the patient. So these are the things where you should not try O-leaf. So to start with, I think we should start with a simple instability with a foraminal stenosis, then go on with instability with a small mild control central canal stenosis, then come back to instability with central disc component. So because coming from obliquely to remove the disc is a bit challenging. Then go to two-level listhesis, and ultimately you can do a degenerative scoliosis also. So I will just discuss the complication avoidance in these steps. So how big is the corridor? Everything, when you do an OLIF, it depends upon the corridor. So there is a discussion like how many people exactly have a corridor. So when we analyzed the OLIF corridor in only spondylosis patients, retrospectively around 100 patients we analyzed. When we found that, and we classified the corridor based upon where the psoas muscle ends and how much gap is there. So we can classify into type 1, 2A, 2, 3, 2B, 3 and 4. So 4 is where there is no corridor. See, this is the corridor. What we see is the corridor is between the psoas and the great vessels. And type 4, you can see the great vessels are very near to the psoas, so you don't have a corridor, and this accounts to around 20%. And we prospectively compared the corridor with time to dock, that means from the skin incision to docking the retractor, and with the muscle injury markers, tissue injury markers, and found that as the corridor becomes more steeper, the difficulty of the surgery, the retraction of psoas also increases. So selecting the initial cases is very crucial, because and you have to need to see the corridor. Another thing is high or steep iliac crest. Now when the iliac crest is very steep and high, definitely it will be very difficult to do a D-lift. But people say because we are entering obliquely, it should not be a problem. But you can reach the disc from obliquely, but all the instrumentation we can't do obliquely. We have to use angled instruments, or we need to work outside the corridor or outside the retractor to do an oblique approach in case of a high iliac crest. So to start with, you don't take a case where you have a high iliac crest. Now positioning. So normally in a D-lift they break the table and do the surgery, but here there is no need to break the table, and we normally in the D-lift we flex the patient, but here we need to extend the hip. What does it do? It does not increase the corridor, but only thing, it will make the psoas muscle taut so that you can feel it easily, and because it is if it is more bulky, then it interferes with your corridor and instrumentation. So by giving a good extension, the volume of the psoas comes down because it becomes taut. Now coming to the incision, first you mark the midpoint of the disc, and from there roughly 5 centimeters. The corridor, they say 7 to 10 centimeters is the area where you can make the incision. So your incision can be vertical, it can be horizontal, or it can be an oblique. So I use a metal thing to first mark the disc. First you have to have a good imaging system where you make a good lateral and AP image, and in the lateral image you mark the center of the disc, and from this point roughly make around 4 to 5 centimeters, and based upon how the patient, I feel if your patient is very bulky, very obese, so if you make a horizontal incision, you can't put your finger and reach the psoas. So in those bulky patients, I like to put a vertical incision so that your the finger can move. For example, he is a bulky patient, so here you make a vertical incision so that your finger can move down till the psoas, and if it's a normal body habitus, I just make a horizontal incision. Now very important thing before understanding the OLIF is the orthogonal maneuver. Orthogonal maneuver is all the instrumentation you have to keep in you have to train your brain, like I have to put all instrumentation, the trial cage, the main cage, even the discectomy, disc preparation, everything should be done in an orthogonal maneuver. So basically the maneuver is like this. You are entering obliquely, but ultimately the cage position is horizontal. So the moment you enter like this, but all instrumentation should be this way. So to get a very good orthogonal procedure, you need to know where exactly you are marked the disc. So the incision should be in line with the disc. You need to mark the opening here, and then have, so that you have to make sure that the opening of the retractor also is in line with the disc space. Because what happens is, if it's not in line, because this is orthogonal maneuver, so you are entering the here, but all the instrumentation is done anteriorly. So though you enter like this, you have to bring the instrumentation anteriorly. So because of this, if the retractor is not in line with the disc, your instruments will hit the retractor. So and you won't be able to do a proper orthogonal maneuver. Now the normal structures always other than the structures in the abdominal wall, once you go inside, three things are very important. One is the genitofemoral nerve that sometimes you can get at L4, L5 level anteriorly. The lumbosympathetic tract. Basically, this approach is the lumbar sympathectomy what the general surgeons used to do regularly. The same thing, only thing is we are putting a tube and doing a discectomy, that's all. So the lumbar sympathetic tract also comes in between sometimes, and you can mobilize it, that is not a big problem. And main thing is ureter. So sometimes you can see the ureter there. So you should not search for the ureter, but sometimes you can find the ureter with the peristalsis while you approach in the retroperitoneum, that can be mobilized. And another thing is iliolumbar vein. So usually across the L5 you can have iliolumbar vein which comes there. So avoid putting a pin on the iliolumbar vein, that is the L5 vertebra. So you prefer to put only on the caudal cranial, that is the L4 vertebra. The pin is to position your retractor, fix your retractor. And everything I do under microscope till I dock the retractor, because some people try to put the retractor under blind vision by palpating with the finger, but I prefer to do everything under microscope till I put the retractor, because there are instances of getting an ureter injury because of the retractor itself. It crushes the ureter, and then you can have hematuria, and then you need to do DJ stenting and all that after that. Now disc preparation. So where to dock your retractor is very important, because the point where you dock the retractor will determine where the final position of your cage stays. So if you dock your retractor more posteriorly, it can enter into more posteriorly. If you dock your retractor more anteriorly, it may come more anteriorly. So ideally, according to Richard Hines, who developed this tube-based roll-leaf, he says you need to dock it at 2/5 of the disc. That is, you divide the disc into 5 parts, and the junction of the second and the 2/5 of the disc, after 2 parts, you need to dock or you can say it is 1/3 or 2/3 of the disc. That is the point where you dock the first dilator. Now this is what I was telling about the orthogonal maneuver. Though as normal spine surgeons, when you do it from posteriorly, the usual approach to remove the disc is like this. You tend to do discectomy by putting the disc forceps in this direction. So if you practice the same thing, you will end up here. So this is the image I am showing. You do without the orthogonal maneuver, if you do the normal discectomy, you end into the canal. So you have to remember that you have to move your hand in a orthogonal maneuver, that is 90 degrees to the patient, so that you end up in the middle of the disc. So this can cause CSF leak, this can cause dural injury. Second case itself, I had a small dural leak from here. So always remember that all instrumentations you need to have in an orthogonal maneuver. Now disc preparation, your cage won't go, because this is a very big cage and you have to put laterally the cage has to go down, means the disc preparation and the annulus part has to be very good. So good exposure of the disc is very crucial. So some amount of the psoas muscle also you can anterior border of the psoas you can elevate to have a good disc clearance, and some blind spots like under the psoas and the anterior most part of the disc also has to be removed. Now another thing is aggressive end plate preparation. So initial cases, subsidence was a very common thing. The most common complication in OLIF is subsidence. So because we do the aggressive disc preparation and over distraction of the disc. So earlier we used to do that. Now the over distraction has come down. So this will cause the subsidence. So disc preparation is to be done, and the breaking the opposite annulus is very important, because the big cage, if it has to go and sit, the opposite annulus has to be broken down, and this has to be done with tactile feedback. If you use a hammer and all that, you can end up going to the opposite psoas. So with a hand, with the help of the hand only, you have to break the opposite annulus with this Cobb instrument. Now final thing, cage positioning. So cage positioning depends again, as I have discussed, about the initial docking point, good disc clearance, complete release of the annulus by doing a Cobb's, and a good orthogonal. All these 4 things are important to know the very good cage position. Now preferred cage position is anterior preferred, because in deformities you want to put the cage more anteriorly, and for indirect decompression of foraminal stenosis, better to put it in the mid or posterior part of the cage. This is what I call orthogonal maneuver. Though you enter obliquely, your cage should go vertically. perpendicular to the patient. This is what we do in orthogonal maneuver. And if you don't do the orthogonal maneuver, it goes in posteriorly. If you do the orthogonal maneuver, it comes into position. So if again the true AP and true lateral are very important. Some rotation also, if it's there, your orthogonal maneuver can go wrong. This is an ideal thing, and depending upon the rotation of the patient, your cage can go haywire. And there are complications of trial going into the posterior aspect and having dural tears. So in a nutshell, complication avoidance, so classify the olive corridor, dead AP lateral, appropriate incision based upon the olive corridor. So, and I'll just show this in a video. So only two things you cut, the skin and the fascia of the external oblique. This is the fascia of the external oblique. Once you have done that, split the external oblique, split the internal oblique. You can see the muscle direction of the muscle fibers. This is transverse abdominis. Split the transverse abdominis. There you see the transverse fascia covering the retroperitoneum. Now with the finger dissection, you go underneath the anterior abdominal wall, roll your finger over all the structures what I have showed, quadratus lumborum, TP, and the anterior border of the psoas. This is the psoas muscle. So now you are on the anterior border of the psoas. These are the structures. This is the lumbar sympathetic range, genitofemoral tract. Now you can dissect them, you can mobilize them until you see the disc. Even the anterior border of psoas, little bit of the anterior border of psoas you can retract, because usually the plexus is in the bulk of the muscle. So once you see the disc, so I do this everything under vision. Then I put the first dilator, that is the 2/3, 1/3 junction, the second dilator, third dilator, the retractor, the pin only the cranial pin, avoid the caudal pin. Now you have the working corridor. Now this opening of the retractor should be in line with the disc, so that you can do your orthogonal maneuver. So the incision will be around 4 to 5 centimeter. Now this is all routine. Discectomy. See, every time, even the cobs also, I'm extending like this in a orthogonal maneuver through the opening in the retractor. Even the cage trial, to put it perpendicular to the patient, I have to do an orthogonal maneuver to enter. This is the trial, and this is the cage. We can use DBM, we can use the bone graft, and this is the cage. Now the beauty of the surgery, everything falls in place. The retroperitoneal fat falls back, the transverse abdominis falls back, the internal oblique and the external oblique. Again, you have to turn the patient back to do the posterior fixation. Now with the navigation and with some screws, which small incisions can be done, we do some cases in only lateral position, where your patient is brought to the extreme of the table and then do. So I'll keep this. These are just some examples. Two-level lysis, degenerative scoliosis. So pre-op planning, case selection, thorough knowledge of anatomy, perfect positioning, retractor alignment, appropriate docking, good disc clearance, and a good orthogonal maneuver and a cage positioning is important. Thank you.
Thank you, Dr. Ramesh, for the excellent talk and the demonstration of the case. How do you decide whether an indirect decompression will be sufficient, especially when there is a thick ligamentum flavum?
The main problem is there is no method to know whether it is because of the buckling of the ligamentum flavum or hypertrophy of the ligamentum flavum. So we need to see other signs of chronic disease like bridging osteophytes, hypertrophied facets, and sometimes you can do the X-rays with a what you call the prone push X-rays, fulcrum X-rays. Normal, if there is no movement in a normal flexion extension, we can put a fulcrum and do a flexion extension X-ray and see for the movement. If no movement is there with all the bridging of efforts, that means we won't get an indirect decompression. So in those cases, OLIF won't work.
So presentation is very clear, so that raises a lot of questions, but I don't have time to ask all these questions. One of the important, you said that you don't do it in a collapsed disc. If the disc is not collapsed, the foramen will not be narrowed.
Collapse means completely fused. In those cases, we can't open up the disc.
Okay.
But some amount of settling should be there, otherwise this won't help.
Yeah, so that is all. Second thing, you use because one important thing is the footprint of the graft, the cage. You have to do a lot of. You have to expand the because usually use a 16, 17, 18 mm cages. So in a T-leaf expandable cage, we go up to 16 or 17. So you have to use a dilator to make the space, such a amount of space. That will create a lot of end plate destruction. And second thing, actually it is an indirect decompression. Indirect decompression you do for a foramen. It is not for the central stenosis. It is lateral.
Severe central canal stenosis, you can't do.
Second thing, you said it is a very minimally invasive, because if you do a minimally invasive, first you do this surgery, then again you have to go back. Are you doing it a miss T-leaf or a miss fixation or a open fixation?
No, we do only
Percutaneous. Then you have to do 2 surgeries.
No.
Because this same thing you can achieve with a T-leaf with an expandable cage.
If you select the case properly, this what I showed the buckling that come out straight. So no need to do a decompression from posterior. But if you
But you have to
central canal stenosis, in those cases we need to open up.
Yeah, but you have shown that area of the lateral lateral recess stenosis and the ligament of flavum there, that pinches the exiting root there.
That's the same patient.
Exiting, not the traversing root there. So that area, that is a lateral stenosis. Central stenosis is different.
No, lateral stenosis, if it is like up and down, cephalocaudal, that will open up. If you have a facet of the facet, superior facet tip coming in, or
SAP,
SAP coming in, and if the antero-posterior foramen is coming narrow, there you can't do OLIF.
SAP, in indirect decompression, SAP won't open up. SAP is the bony decompression.
In those cases, you can't do this.
Yeah.
I'm telling that. In these cases, you can't do that.
Because the disadvantage of this technique is this is not a minimally invasive, because you have to do 2 surgeries.
We have compared our results with OLIF and MIS T-leaf.
Yeah.
So we have published also.
MIS T-leaf, what type of cage you use?
Normal cage.
Normal. That is the problem. You have to use an expandable cage that you can achieve 16, 17 millimeter.
So literature has already shown that OLIF, because we are not removing any bone, we are not removing any, we don't see the dura, nothing is in here. So in this what we have seen that the return to work and the hospital stay is completely reduced.
Another thing, you are putting a parallel cage there, because always the lower angle of the lumbar lordosis is very important.
No, it's not a parallel cage. Again, it has 3 types of cages because based upon the disc type. So if you have a biconvex disc, the cage differs. If it's a parallel disc, the cage differs.
Any question from the audience?
That we have some vertical movement and of course the lateral bending and lateral translation. The problem is most of us actually look at just the antero-posterior movement, and we look at dislocation, or whenever we talk about the atlantoaxial dislocation, we talk only in the antero-posterior plane or at the most some concept of the vertical dislocation or the so-called basilar invagination. So it is far more than that, and it is, we have, as I said, 6 degrees of freedom of movements, and each plane there could be dislocation or in singularity or in combination of each other. So we need to address the dislocation from that perspective. So of course, the joint stability depends upon the facets. So if you have abnormal disposition of the facets, it's going to dislocate with time. And there's a role of the ligaments as well. Incompetent ligaments could give rise to dislocation, especially the reducible variety, and this is often seen in the rotational or the anteroposterior plane. This is a scan of a normal individual, and you can see that the C1, C2 are almost parallel to the ground. Whereas if you look at a patient with congenital atlantoaxial dislocation, look at the deformity, the C1 is oblique, and it is as if the C1 is slipping over the C2 with time. This is going to make the C1 move anteriorly and inferiorly with respect to the C2. So this is what we had looked at the joints in a large number of patients, and we realized that the C1 in majority of the cases was assimilated, and we could see that it is oblique, not only in the sagittal plane, but also in the coronal plane, and that is the comparison of a normal individual with the ones with atlantoaxial dislocation, the congenital variety, of course. So you can see that the joint is C1 facet is quite oblique. The C1 is actually slipping over the C2 because of that obliquity, and this angulation would actually determine the anterior slip of C1 over C2 and the time at which the patient would present. So as I said, it is not only in the sagittal plane, but it also happens in the coronal plane, where you can see that the angulation will decide the plane of dislocation with time. So this is the philosophy and the concept that the patient is not born with a dislocated joint. The patient is actually born with a deformed joint. And as depending upon the obliquity, depending upon the angulation, the C1 would slip over the C2 in a glacial format. So it's a glacial slip. It's not something that is fixed. So it is a dynamic process. So even if with time it continues to dislocate to a point where it will start becoming symptomatic, compressing the cord, and beyond a particular level it will just not reduce. Even though there is movement on flexion extension, the C2 anterior margin would act as a fulcrum in the facet, making the C1 actually move in the flexion extension format over that little point. So all this was obviously published, and you need to study the CT in multiple planes so that you can actually determine. So it's not only the sagittal images, coronal images, but also in the axial. So all 3 planes, as I said, 3 planes and 6 degrees of freedom of motion. So you need to study the scans in all the 3 planes. So this is an example of the anteroposterior. You can see it has just moved in front. There is translation. So this is a translational kind of dislocation. The joints are almost normal. C1, C2 almost normal. And this is a plane where rotational, so axial, the normal movement has been exaggerated, and the facets just slip in clockwise or anti-clockwise manner, and then finally locks over one another, giving rise to this kind of dislocation or the Koch-Robin appearance. This is the one which I was talking about, the vertical dislocation. Now look at the facets in the coronal plane. Now they are quite oblique, as well as some obliquity seen in the sagittal plane. So that gives rise to a progressive slip of the C2 within the C1. That is telescoping of the C2 within the C1, or the vertical dislocation. The so-called basilar invagination is actually a dislocation of C1 and C2, and not actually truly a basilar invagination. I'll come to that later. So this is a combination of the dislocations. You can see anteroposterior, vertical, and that's all. It is because of the facets which are disposed in an oblique manner. So just imagine that if one facet is more oblique as compared to the other, it is going to slip faster. As I said, it's a dynamic process. It's a glacial slip of the C1 over the C2, and the more oblique facet is going to slip faster and quicker as compared to the opposite side, giving rise to a rotational component to the dislocation. So that's an example here. You can see one side is more oblique as compared to the other, and that's the reason why it has slipped. You can see that it slipped more, and there is axial rotation as well. Of course, as I said, we usually look at the anteroposterior and the coronal planes, but we don't look at the lateral or the coronal plane, where it can translate And this is an example where it has translated. Of course, this is usually associated with os-odontoideum or the fracture of the C2. Or you can have an angular tilt. You can look at the, if you carefully see, look at the the C1. Here the C1 facet is almost lying close to the C2, C3, and as compared to the other side where it is normal. So this kind of coronal inclination, you can look at the joint, it is vertical on one side and almost flat on the other side. This gives rise to a continuous angular tilting, giving rise in the lateral plane or the coronal plane. So this is a lateral angular dislocation, and most of us would actually think that this is simple anteroposterior, but if you look at the coronal plane, no, it is much more than simple anteroposterior dislocation or vertical dislocation. Again, all this was published, and this is the thing which I was talking about. There is a clear-cut difference between basilar invagination and vertical dislocation. The lower images represent the basilar invagination, the vertical dislocation. Why? Because the relationship between the C1 and C2 is all, this is the relationship between C1 C2 is dislocated. You can see that it is aberrant and it has gone up. Whereas if you see in the upper row, the C1 C2 is unaltered. It's all in that same plane, but it is totally invaginated. The base has invaginated. The condyles are way higher up than the palate. So that is the true basilar invagination as compared to the vertical dislocation. But it's a matter of nomenclature. So obviously, having said that, now there were multiple approaches in the past. It all began with midline approaches, sublaminar wiring, transoral followed by this, lateral approaches where occipitocervical fixation. Even now, a lot of people still would like to do occipitocervical fixation, especially in assimilated arch of atlas, thinking that it would not make any difference. But that difference is only, or no difference is only in the perspective of the movements, the range of motion. It is, it's not actually as effective as the direct C1, C2 fixation. So this is what we have actually popularized and been describing. So this is the procedure of a direct posterior open reduction. The concept is based on the philosophy that these joints are oblique and deformed. So you correct the deformity and the dislocation would reduce, and finally you need to fix it in the reduced position. So that reduction, so we came up with a mathematical formula by which we can determine the amount of facet that can be drilled. It's a wedge osteotomy. It's just a wedge osteotomy as you do for a scoliosis correction. So it's a wedge osteotomy of the C1 and C2, correct the deformity not only in the sagittal plane. Again, the most important thing, it has to be corrected in multiple planes. So the release has to be done in the anteroposterior as well as in the coronal plane. And so this is the additional part of the wedge that needs to be removed, the antero-inferior part of the C1 facet, the posterior-superior part of the C2, and the amount of bone drilling is not much. Actually, it is just about 1 or 2 millimeters, or at the most 3 millimeters, not more than that. And that amount of bone that needs to be drilled needs to be replaced with some kind of spacer. So the degree of dislocation or the so-called basilar invagination does not determine the height of the spacers to be used. It is because if you reduce it, you don't need any kind of spacers. But obviously to achieve that reduction, you need to have these kind of wedge osteotomies, and for that needs to be replaced with some kind of a metallic spacer so that it does not, the bone grafts just don't resorb and there's no settling in the future. So that again was published, and then this is, this is an example where the yellow wedges, that's a wedge osteotomy, and you can just achieve that kind of reduction. Now, after you have achieved some sort of, at times, despite all that reduction, you need to add on to some maneuvers. And this is what we have. I mean, there are multiple techniques to do that, but this is one of them. And what we do is we insert a C1 screw, irrespective of whether it is assimilated, not assimilated, a C1 screw and the C2 pedicle screw, and it is loosely fastened. It is not, and the spacer cannot be jammed. If you have a jammed spacer, you really can't maneuver all this. So once it is done, loosely fasten it with a rod, and just, you can twist it in the craniocaudal direction to achieve the anteroposterior realignment. And this is an example where you have done it by direct posterior reduction, no need for transoral. This is another example where you have achieved all complete reduction without any transoral. even in the rotational plane. You can see that it is corrected in all the 3 planes. If it is in the lateral plane, of course, the same maneuvers, you can use it by insinuating an osteotome and just turning it around by the, in the clockwise or anti-clockwise manner, depending upon the dislocation, the plane of the dislocation. So this was actually described by Goel, but we modified it further by putting in again the C1 and C2 screws and just holding it, the loosely fastened rod, and you can just twist it in any direction you want to achieve that kind of realignment. Of course, once you have done all that, you need to jam the spacers finally so that it doesn't keep on moving beyond that after your correction has been achieved. So again, all this was published. So this is an example of the lateral angular dislocation. It's quite, as you can see here, there's excessive lateral bending. You can see the C1 facet, but look at the OC joints are all intact. So we don't really want to fuse the OC or the occiput with that. And you can, if you can achieve this, if you can swing the C1 or the C2 below the C1, that kind of reduction can be achieved. And this is again, you can do a wedge osteotomy mainly in the coronal plane and just swing it back. And this is an example here. You can see this was a progressive move, pictures of the child over the period of 4 years. So it's a dynamic process, keeps on dislocating, and finally the child came to us in a bedridden form, and this is post-surgery. Another example where you can see complete dislocation, lateral dislocation of the C1 over the C2. It is lying close to the C2, C3, and that can be swung back to its position, and you can fuse it without actually fusing the occiput to the cervical spine. So that is a schematic representation of the same thing. Again, all this has been published. So this is a very small, I'm going to skip the video because it's going to take a long time. So we don't have that kind of time. Of course, while reaching up to those joints, you have challenges. You have anomalous arteries, you have pseudofacets. So, this is the normal artery, should not cross the joint. Even if it is assimilated, it would cross above the C1, and there's a canal in the bone through which the artery would pass. But in cases, in almost 1/3 of the cases with these kind of assimilated arch or complex CV junction anomalies, you have the anomalous course, and there is a possibility that this artery can be injured during surgery while opening up the joints or while inserting the screws or spacers. We came up with a technique of mobilizing it. We have described a variety of vertebral artery anomalies, and all these anomalies can actually be mobilized. You can skeletonize the artery, and you can just gently retract it cranially or caudally while inserting your screws or opening up the joint. So all this again has been published. So this is an example where you can see anyway, so again, it's not a deterrent, and there's a operative video published in Operative Neurosurgery for both the techniques. And if you have, I usually prefer to put in a C2 pedicle screw. That's very important, because if you put in it gives you a very robust kind of construct, and you can, for the maneuvers which I had described, you need actually a very robust screw. You don't need something that can be pulled out. A power screw is not very strong. It just provides about 10 to 12 mm of purchase, whereas this pedicle screw you can go up to, if you direct it medially, you can go right, use almost 22 mm of screws for a bicortical purchase. So that is extremely strong, and especially, but if you have a high riding vertebral artery, you need to just go medial to the vertebral artery here, and you can insert your screw directly inside the C2 body. So that's a subfacetal screw, and then you can do the same maneuvers which were described. So that's previously we used to cut the C2 nerve root. Now I don't do that anymore. You can skeletonize the nerve root just like the anomalous artery. Even that can be maneuvered and retracted. So that's a small video which I think I have a minute or two to play that, and that's the dissection of the C1, C2. You can see the nerve root would be preserved now, and we cut open the capsule to open up the joint. That's the capsule, the posterior capsule, and that's the nerve root. There's a small anomalous artery as well passing along with that nerve root, and that is, so this is why this small video actually demonstrates everything. You can see the small vertebral artery there. So you can just, there is a venous plexus, but if you carefully dissect it, you can actually get away without much bleeding. So that's the skeletonization of the artery as well as the nerve root. And joint has been opened. I'm not going to show much of drilling in this video. We don't have that kind of time. So the C1 facet, even if it is assimilated, you can expose it very nicely. You can drill a part of the occipital bone which is actually, hindering your view to that. That's the final exposure after it has been mobilized. And, further manipulation. So I'm just going to, rest of the things are very, most of us would be aware of that. So that's the drilling which I was talking about, and you just insert after the spacer or the bone graft, you just put in your C1, C2 screws and maneuver whatever is required. I'm not going to these were pseudo facets which come into your way, and that may be a cause. They look like a normal joint. In fact, Professor Chandra has, subsequently, he described to use them to put in your spacers, but I feel that it is not physiological, and that is not something which I would like to do. So these were the pseudo facets which we had described, and but of course, so these are a couple of examples where you can see significant dislocation achieved, posterior reduction by just C1, C2 fixation. And another example, multiplanar, you can see in all the 3 planes you have dislocation, and it can be reduced by just your C1, C2 maneuvers, and it can be fixed with screws inside the C1 lateral masses and the C2 pedicle. So in younger patients, in children, in extreme elders, so we have actually published in various age groups multiple techniques. So to conclude, the facets and their orientation, they play a major role in the atlantoaxial dislocation. The C1, C2 joints can dislocate in multiple planes, and we need to study them carefully on the CT scan. We have to drill them comprehensively to near normal shape. Of course, we need to be aware of the pseudo facets. If we drill too much of pseudo facets, you may have bone loss, so that needs to be taken into consideration. And if there's an anomalous artery, that's not a deterrent. You can safeguard it, realign them using the joint manipulation as I showed you, and of course fuse the facets as close to each other, not the occipital squama to the C2. Thank you.
It's something, there are a lot of controversies there.
Yeah.
I remember I read a paper with Sharat Chandra dividing this oblique joint into 1, 2, 3.
Yeah.
And you have seen some complicated mathematical equation
Yeah.
there.
Yeah.
How your classification differs from Sharat Chandra for the betterment of management?
Okay, so see his management, actually he has classified them into the degree of obliquity because his management differs with each one of them. So for example, if you have a less oblique joint, you can just insert your spacer in the C1, C2 joints and finally fix the occipital squama to the C2 by compressing them. If you have too much of oblique joint, extremely the so-called vertical joints, he labels, he uses the pseudo facet, he puts an extra articular spacer, a large one, cage, and then again compresses that using as a fulcrum. To me, I don't actually agree with that because any joint, as I said, they are born with a deformed joint, not with a dislocated joint. So you need to do a deformity correction rather than just trying to, use the occipital squama and fix it like your sublaminar wiring, which was done in the past. So finally, it's like hyperextension to achieve that kind of reduction. And if you're putting your spacer on a small isthmus and between the occipital squama, it is likely to slip with time. In fact, I get a lot of these cases which have been referred because of its failure. Not done by Professor Chandra, but done somewhere else because the technique appears to be very easy, but it fails in the long run. It just doesn't work. The occipital screws pull out or the spacers just slip. So we have a lot of examples now.
So in many of these cases, there will be C0, C1 fusion will be there. So we have to be forced to do a C0 fixation there.
Yes.
So another thing is, basic is the distraction. Because it's just like a spondylolisthesis.
Yes.
Because the lax ligament
Yes.
create these
Yes.
things or an oblique joint.
Yeah.
So how you are drilling it and making it flat and then putting the cage.
Yes.
Then
So it's just like
how will you decide it will get enough distraction there?
No, it's just that once you release the joints, the idea is to release the joints from the posterior, whatever approach you choose, anterior, posterior, you just need to release the joints. So if you release the joints and after that just push the C2, you can push the C2 or pull the C1 back. Either ways it is going to get realigned. So the spacer is just to, because whatever amount of bone was drilled, to release the joints. The idea is to release the joints. At times you have the whole thing overhanging the C2 facet. So that is the amount of bone that you need to drill.
But usually the footprint of these joints, opposing surface won't be parallel. So we cannot put a cage there.
No, actually they are, that's what I'm saying. So they are born with a deformed joint, but you can imagine the foot plate is, in the normal thing would be like this. In this deformed joint, it would be
like
oblique.
Like that.
So, but it remains parallel to each other. The slipping it, but after it has slipped in front, it will become like this. So it appears that it is not congruent, but ideally they were born like that. They were born in that congruent manner, though it is deformed. So that's the whole idea. And we don't drill too much because initially in my, we came up with this technique in 2011, 12. So in those days, I was forced to do a OC fixation because I was not comfortable drilling that much. And at times I drilled too much to lost the bone stock to in fact get a good purchase of the C1 screw or CO screw.
So regarding the wedge osteotomy, so how do you know whether you get enough bone, especially when there is a high riding vertebral artery, the bone below the facet will be too thin.
Right. So what I do is exactly you initially put in your chisel or osteotome and just turn it around. Just turn it around. During your turning, you come to know that the final thing is to look at the anterior capsule, because that is how you know that. So if you don't see the anterior capsule, but at least you know that this is the amount of bone that needs to be drilled. Because as I said, if you don't do that, if you don't insinuate an instrument and turn it around, there's a lot of bone that will be drilled. So the osteotomy needs to be, you have to minimize the osteotomy.
Okay, and regarding in such cases when there is a high riding vertebral artery, and especially in children with lamina is too thin, what is your option for?
I don't use a laminar screw actually. Okay. I have to put it inside the body, whether it is a subfacetal or a pedicle screw.
Just a quick comment. I just want to reiterate what Praveen has told so eloquently. It's not easy to enter these joints, especially in the more difficult congenital variety cases. But if you train yourself, if you are able to enter those joints, and if you are able to manipulate those joints, break the joint, make them loose, even the anterior joint, enter capsule, or Dr. Ramesh also talked during his talk, you have to get access to the other side. Once you break them, and then they are amenable, and absolutely for me also, occipital C2 or C3, C4 fixation is a substandard surgery. There's no doubt. You have to catch the bull by the horn, and that is the C1, C2 thing. It's not easy, absolutely it's not easy, but you have to try, and if you can get there, enter the joint and release it nicely, there's nothing like it.
So very nice talk, and personally I have around 7 to 8 cases being done in the same way with Dr. Samir, who just happened to be a student of Sir. So the basic pathology, as Sir told, is around C1, C2 joint, and once you make them parallel, the joint falls back and you can use them easily. So my only worry was to understand about the pseudo facets and how to handle them and manage it.
Actually, see, these are for maybe it's a congenital aberration, we don't know, or it is a developmental pathology because of the continuous touching of the occiput squama to the C2, the isthmus. So we don't know what is the actual thing, but there is a hypertrophied bone there, at times even a cartilage, and you can just shave it off. But if you because if you drill it over aggressively to correct it and to reach up to the true joint or the true facet, that at times could give rise to a lot of bone loss, and the lamina and the isthmus becomes very small. Even the pedicle becomes very small, and while putting in your screw, it might just break, especially while you're doing the maneuvers. So I still remember, I think Nupur had presented somewhere his 3 different techniques to actually reduce. the C1, C2. So you can just push the C2, but all that requires release of the C1, C2 joints. That's the most important thing. It may not be, that it's an exaggeration that you want to make the facets flat. That's the concept, but the idea is to release them. You just need to release them completely. Whether you approach as posterior, anterior, you need to release the joints completely. Once they are released, you can just maneuver. You can use any maneuvers and you can fix them close to each other. Yeah.
So is there an assumption that is the only thing which is holding on, or we are just using it as a way to release?
No, actually the thing is, this is backed up by a lot of experience now, because I've been focusing only on the CV junction in the spine. I don't do any other spine. So the numbers have gone almost up to 800 cases now, and it is this was the only problem which was. So if I have not released it completely, it will not reduce, or there is a construct failure later on.
So there may be some other soft tissue which is
Soft tissue, yeah, but soft tissue is usually you can easily, it's very easy to release the soft tissue. Yes, so if you just use it once, if the bony thing is gone, because you have to release, you have to see the anterior capsule right from medial to the anterior, medial to the lateral portion completely. So once it is done, then there's nothing which is holding it back.
You need not cut it open.
The anterior capsule, it's actually dangerous to cut it because at times you have the carotid, the carotid's passing very close to that.
Another thing is like, how will you manage when the screw tooth gets too close?
Oh, okay, fine. So that's the usually the commonly available screws in the Indian market, they have larger tulips. So the Western ones, they have smaller tulips. So I think now Jeon and Jesco, they have come up with very small tulip screws also. So they are good enough. But to avoid that, you have to create enough space just above you can drill a part of the occiput for the tulip to fit in there.
It's not just the occiput, the lower, both will be very close.
Yes, very close, but once you do that, there is enough space. And if the joint is it has to be close to, with the spacer of approximately 4 mm, you still have the space between the two tulips. Yeah.
Okay.
Thank you, sir, for this enlightening talk. I now request Dr. Tinu Ravi Abraham, sir, Professor Neurosurgery from Kottayam Medical College. He will be talking on spondylodiscitis, a review of current management guidelines.
Excuse me, sir. Small announcement. Dinner will be at 8:30 after the session at the same venue. Thank you.
So, a very good evening to all the respected faculty, friends, colleagues, and the residents who are present over here. Sorry for that. Oh, and I'll be having a So I'll be doing a review on the current management guidelines. And beforehand, I would like to make a disclosure that in contrast to the spectacular presentations you have seen here, my presentation is going to be more like a theoretical like a presentation, which might be more useful to the residents here. So straight to the topic. rather than the term spondylodiscitis, vertebral osteomyelitis is actually the broader and apt term because it covers all the types of infections of the spine. And you know that it has been pathologically categorized into pyogenic and granulomatous variety. Pyogenic being caused by staphylococcus and some gram-negative bacilli, and granulomatous caused by tuberculosis, brucelli, fungi, etc. And if you see the epidemiology, recently there has been an increase in the case of pyogenic spondylodiscitis or vertebral osteomyelitis. The main reasons being the increase in the number of intravascular devices and implants being placed. And as you know, tuberculosis is still one of the leading killers in developing nations. And regarding the pyogenic osteomyelitis, the most common is Staph aureus, with an alarming increase in the MRSA infections very recently. Regarding the tuberculosis, everybody is familiar. Now, you get a patient with a spine infection with a MRI picture like this. So how will you proceed? So the basic idea is, first you would like to classify the infection into whether it's a pyogenic or is this a granulomatous. Then you would like to confirm the diagnosis in each group and proceed with the management accordingly. So what are the factors in which you should have a suspicion of pyogenic osteomyelitis? Now, 3 situations you have to remember. One, a patient with a new or worsening back pain comes with either a fever or a recent evidence of septicemia or infective enteritis. Second situation is when a patient presents with fever with peripheral neurological symptoms, with or without back pain. And the third situation is when the patient has a new onset progressive back pain which is not responding to any other modes of standard therapy. So in these 3 situations, you consider the diagnosis of a pyogenic spondylodiscitis clinically. And in tuberculosis, the clinical suspicion is very difficult to make because it's more like a very indolent type of disease. And the only positive history it might get is a probable contact with a TB person, or the patient himself may be having some possible infection in the past or present, like that. And the other differentiating features are, although any vertebral body can be involved in a pyogenic infection, the lumbar vertebrae is mainly the most commonly involved in a case of pyogenic, whereas tuberculosis affects mainly the lower thoracic and the upper lumbar. And the severe back pain seen in pyogenic infections has got a very, the progression is very short. That means within days to weeks the disease progresses, whereas in TB this progression is very long. And the constitutional symptoms are more seen in pyogenic compared to tuberculosis. This is the classical Alderman's gait which was described for the tuberculous spondylodiscitis. And the clinical is over. Then radiologically, how will you differentiate between pyogenic and tuberculous? I will describe it in terms of with this picture. On the left, you have the pyogenic, and on the right, you have a tuberculous. So when you get a MRI of a patient with suspected spine infection, first you look at the disc space. You can see the disc space is involved in this picture. This is not coming. Okay. So first you have a look at the disc space. If the disc space is involved, it is seen in pyogenic spondylodiscitis. Whereas in TB, the disc space is relatively preserved until the advanced stages of the disease. Then you look at the intensity changes in the vertebral body. Pyogenic spondylodiscitis will have a uniform type of signal changes in the vertebral bodies, whereas the tuberculous will have heterogeneous type of signal changes. Then you look at the vertebral body destruction. In pyogenic, usually the vertebral body is preserved, whereas in tuberculous, you can see that the vertebral body destruction is more. Then you look for the extension of the collections subligaminously. Here you can see the collection is extending anteriorly, subligaminously beneath the ALL. And the other points you have to look for in the MRIs are the involvement of multiple vertebrae, the presence of psoas abscesses, presence of gibbous, etc. So once you come to a diagnosis after your clinical and radiological evidence, you have a diagnosis of pyogenic infection. Then how will you confirm your diagnosis? So for that, at least one of the three following factors should be positive. One, clinical and radiological evidence of osteomyelitis with a positive blood culture with a typical pathogen. You know that the typical pathogens which have already been described, such as Staph aureus, streptococcal B, C varieties, gram-negative bacilli, and all you know. So positive blood culture with a typical pathogen. Then second is a bone biopsy which is consistent with osteomyelitis in the absence of a blood culture. Or third point is, even if the blood culture, or in cases where the blood culture is negative, in cases where the bone biopsy could not be done or is negative, but the patient is having persistently elevated inflammatory markers, mainly the CRP, ESR, counts, etc. In the third case, again, you have to rule out other causes of back pain such as malignancy and everything else. So any one of these points plus clinical and radiologic evidence means you can diagnose it as pyogenic spondylolisthesis and proceed with your antibiotic treatment. Now, there is a medico-legal implication in considering this diagnosis, because you are going to start strong antibiotics, that 2 or 3 or 4 weeks antibiotics without a pathological diagnosis. But this evidence is there in the literature, and I have shown one of the references here. You can very well quote it for your medical legal confidence. Then confirmation of tuberculosis is possible only through a proper microscopy and culture. And it is often at this stage, that is the stage of biopsy, that neurosurgeons come into the field, and all the residents should be well aware of the proper biopsy technique. You all know that the biopsy can be taken in a case of a spine infection through either open percutaneous or with the coming of endoscopic techniques. But what will be the technique? You have to be careful in 2-3 aspects. One is the biopsy has to be taken from the disc space as far as possible, because the highest microbiological yield is from the disc space. Second is you have to take at least 4 to 6 samples. 6 samples is recommended in many of the studies from different surgical fields. And endoscopic biopsy, if it is available, is the procedure of choice nowadays, because you can simultaneously drain the infection, you can do a reasonable curating, simultaneously you can get a biopsy from the disc also. And once your biopsy is over, what are the tests to order? First of all, histopathology, as you know, to confirm the diagnosis, but also to rule out other diseases such as malignancies. Then the other cultures, aerobic, anaerobic, mycobacterial or fungal if suspected, like that. And many of the surgeons have a tendency to send only fluids for culture, but it is wrong. Even the biopsy specimen directly put into the culture media or the inoculum, it gives a very high microbial numbers. And suppose what happens if your biopsy comes as negative? Would you put your patient into a second surgery? So this in this area there is a controversy, because some of the papers say that you get a higher yield during a second biopsy, but some of the papers say you get a low yield. So again, the decision is upon the neurosurgeon and the patient. And once you make a diagnosis, how will you go on with the management? What are the management guidelines? Now, if it is a diagnosis of a pyogenic spondylolisthesis has been made, you have to consider it as a life-threatening condition. So a very aggressive approach to treatment has to be taken. And the classic approach of getting a biopsy done, waiting for the biopsy result to come, and then starting antibiotics, it is gone. Now the strong argument is for starting anti-staphylococcal treatment as early as possible, even before the biopsy and the culture results come, because it has been found that in more than 70% of cases, the infection is caused by Staph aureus. And again, you have studies to support your treatment plan. And the choice of antibiotic is usually very clear, because for methicillin sensitive Staph aureus, the antibiotic is first generation cephalosporin. In MRSA, the antibiotic of choice is IV vancomycin, and if vancomycin is allergic, you can give teicoplanin. And in MRSA, always you give 2 antibiotics at least. And the second antibiotic you would like to add is either rifampicin or fusidic acid, as suggested in many of the studies. And there is a bad tendency to use linezolid in a lot of cases, but linezolid should be reserved only for resistant strains such as HVISA, which stands for heterogeneous vancomycin intermediate staph aureus. And of course, if it is a gram-negative organism, you can give a third generation cephalosporins. And whatever be it, depending upon the clinical response you monitor, then after starting the antibiotics, you can either continue with your empirical treatment or you can change over to the antibiotic which has been obtained during the culture studies. And this point is also controversial, because whether to continue with the empirical treatment or you start with a specific antibiotic, again there are papers for and against this point. So again, I think the better option would be to go with the antibiotics which has produced a better clinical response. And the controversy regarding the duration of antibiotic treatment still exists, because many of the surgeons feel they have to give 4 to 6 weeks of parenteral antibiotics. But the latest studies have shown that this is an over treatment, and a large trial has been brought out. It was a study in Hong Kong, I think. So they have suggested that a 2 weeks parenteral antibiotics followed by oral antibiotics is sufficient, provided you satisfy 2 criteria. That is, the CRP should have been brought to control before switching over to oral antibiotics, and also at least a sufficient amount of necrotic or infected material has been drained out. And what do you monitor during your antibiotic therapy? 2 monitoring should be done. One is to assess the clinical response, and one is to assess the side effects of the antibiotics you are giving. The clinical response in terms of monitoring for the pain, fever, etc. has to be done, but you have to bear in mind the fact that these symptoms will take a certain weeks to respond. The best parameter to monitor would be your lab values, especially CRP, because CRP will take only weeks to get normalized, whereas if you monitor ESR, it will take months to get normalized. Now, the usage of imaging as a tool for monitoring is not advisable, because there is a gross discrepancy between the clinical response and the imaging response. We often find that even if a patient is improving drastically, the MRI findings may be getting bad. So still MRI or the imaging is used as a modality in monitoring, because you want to monitor for development of new deformities or progression of the old deformities. That is the only indication. Now during your response, you see that there is only a partial response or no response at all. There should be no hesitancy in starting off with a second course of parenteral antibiotics, because it is a life-threatening condition if it is a pyogenic osteomyelitis. And for that purpose, you can even put a peripherally introduced central venous catheter if you are planning to give longer periods of IV antibiotics. And always monitor for the development of deep vein thrombosis or venous thromboembolism, because these patients are very prone due to the infection and also due to the immobility produced by the spine infection. Then regarding the TB spondylodiscitis treatment, there is not much controversy apart from the duration for which you give the ATT. So there is a general tendency among the physicians to give treatment for 12 to 18 months, fearing the drug resistance and the indolent nature of the disease. But many large trials done in Hong Kong, Korea and India, some of the studies I have shown below, they have proved that 6 to 9 months of ATT treatment is enough for the control of spine TB. Coming to the surgical management, whether it is pyogenic or TB, the basic indications for surgery is worsening of the clinical symptoms while the patient is on conservative management. Second is if there is a significant disability beforehand or during the process of monitoring, patient develops new disabilities, or if the patient has significant deformity, especially if the kyphosis is more than 40 degrees, or patient develops new deformities during the treatment of conservative treatment, and in any instance if the patient develops an epidural abscess. These are the broad indications for surgery in these patients. And whatever be the type of surgery, the main aim of your surgery should be to debride the entire necrotic area as far as possible. You have to decompress the neural elements, then restore the anterior column and stabilize the spine segment if indicated. And regarding surgeries, I think the surgeons are all very familiar with the various anterior, posterior and the combined procedures. Among the anterior procedures, it was radicalized by the Hong Kong technique. Hong Kong technique is nothing but radical debridement of the anterior areas with strut graft fusion. But always this Hong Kong technique is not done per se, it is combined with posterior instrumentation because the instability created is very high. And the graft, you have an option to use allograft, autograft, whatever. And the anterior procedures for cervical is very familiar. The thoracic anterior procedures include mini-thoracotomy or VATS for debridement. And the posterior approaches in which the classical laminectomy is used is only used when there is a posterior element involvement only, or if there is a epidural abscess. Otherwise, multiple level laminectomies without fusion is not recommended because your anterior column is already under suspicion of instability. Then ad hoc procedures like posterior coastal transversectomy, lateral extracavitary approaches, all these the surgeon should be familiar because you may need to use it in cases where the pathology extends to higher levels. And combined procedures are there. One or two controversies in the surgical treatment you should know. One is regarding the presence of doing the instrumentation in the field of infection. So it is true that the Staphylococcus aureus has a chance of developing a biofilm. But this fear of developing biofilm occurred in an area in an era when steel implants were used. Nowadays we have got medical graded titanium in almost all implants, and so the chance of biofilm formation is very less. And if you talk about tubercular spondylodiscitis, the chance of biofilm formation is still extremely less. So it is definitely recommended to do instrumentation and fusion in the area of infection itself. Then regarding the decision between the usage of interbody cage or autograft, many of the surgeons nowadays prefer using an interbody cages because of the strong mechanical support, and these are friendly to the osteoprogenitor cells, and it can avoid the morbidity of taking a tricortical graft like graft site morbidities and all. And also there is a chance of bone resorption and loss of vertebral support secondary to it if you are using a bone support. So interbody cages are the preferred one, but still the fact remains that the fusion rates are very high to the tune of 97% at 10 years with bony fusion compared to instrumentation alone. The use of recombinant bone morphogenetic protein, still we do not have any good evidence to support its use, but still it is being used on a trial basis. So I will conclude my talk with our experience at my institution. We did around 131 cases for the past 3 years, which with the incidence of spondylodiscitis increasing year by year. And this is the pathology-wise split of the cases in which TB spondylodiscitis was the majority in all the years. And last year we also had aspergillus spondylodiscitis. And for the study purpose, we did a standard, procedure, we did the posterior procedure, open procedure, in which the pedicle screws were put first of all using a freehand technique under Siam guidance, and circumferential decompression in the form of laminectomy, followed by extensive anterior debridement via transpedicular or costotransversectomy or lateral extracavitary approach was used. And this was followed by a rod fusion and posterolateral fusion using autograft bone harvested from a normal spine and sometimes mixed with G-bone also. And the recovery or the functional outcome was measured in terms of fascia score and Frankel's grading, and both of these statistics showed there was a significant improvement in the functional outcome. Except for some 2 to 3 paraplegia patients, all the patients had very good functional outcome. And the most striking outcome was seen in the pain scores. There was significant pain improvement for all these patients. And out of the 131 patients, we had complications in only 5. And so I will conclude my talk. These are some of the post-op X-rays we had. So thank you for the patient listening.
Thank you, Tinu. There will be a lot of questions maybe. The topic is open for discussion.
Very excellent presentation, and it has some doubts are, so many doubts are cleared. But I have some 3 questions. One regarding, you said about the endoscopic biopsy, because you know for for years we start off a cold abscess and a fistula formation following a biopsy. Is it there? Second thing, many a time the problem with the pyogenic or TB osteomyelitis, they are at a conservative regime, and the point where the patient start deficits, we see the patient. So, can you kindly say the what exact point the surgery is indicated? What exact point and what are the for the usually they may be under the physician or somebody else. Third thing is regarding the multiple, because nowadays the pyogenic is on rise because of urinary infection, chronic urinary infection. What about the mixed infections with the TB and?
The answer to the first question, I do not have personal experience with endoscopic drainages, but still the literature says endoscopic drainages are the best because of the reasons I already stated about. Now regarding the delay in the patient reaching the surgeon, as I advise, the monitoring of the patients should be done on a regular basis. It is not like that if you start the antibiotics and you send the patient away. Monitoring should be done on a regular basis with CRP, the clinical monitoring as well as the imaging follow-up. The imaging is used as a follow-up mainly to identify these deficits. A patient who is going in for kyphosis, that means if you know that around the kyphosis around 40 degrees, means the patient will be going in for deficit, and this has to be treated surgically as early as possible. And regarding the mixed infections, is one of the reasons why you start with empirical antibiotics and you do the cultures, and then the decision is upon the surgeon. You can give a broad spectrum antibiotic. Basic idea is that you monitor for the clinical response. So if the patient is not improving, you can do a repeat cultures and you can start a second set of antibiotics. So definitely there is no definite answers for that, but still it is all the physician's discretion.
Regarding the diagnosis of TB, so what is the criteria for diagnosing, whether it is a biopsy proven or, and what is the role of empirical? Is there any role of empirical ITT?
Sir, actually, as I told, the clinical diagnosis is a bit difficult because it is very broad, because it can mimic any other disease. But the radiological, you can have an idea because of the amount, by seeing the amount of bone destruction and the soft tissue abscess and all, you can have an idea. And the histopathological diagnosis is very important because you need not identify the acid-fast bacillus, but the presence of epithelioid granuloma, it is almost 87% specific in diagnosing TB. And the presence of a granular cytoplasm, cytoplasmic background, again has a specificity of 76%. And the presence of lymphocytic predominance. These are the findings which has got specific specificities. Lymphocytic predominance has got 66% specificity, and giant cells, Langhans giant cells, has got 56%. So with a combination of all these findings, you can come to a diagnosis even if you do not identify an AFB through a culture. So clinical, radiological, and some of the SPR findings can confirm the diagnosis.
Okay, thank you.
Thank you, sir. This brings us to the last talk of the day. I now request Dr. Ganesh Divakar, sir, from CHITRA NEUROSURGERY Institute to enlighten us on access to the upper thoracic spine, surmounting the sternal hurdle.
Respected chairpersons, senior faculty, colleagues and residents. See, we are coming to the end of the first day sessions. This is the last topic, and as you are all prepared for dinner, I'd like to rush through the some experiences we had regarding the some lesions of the upper thoracic spine. Elaborate. Okay, so the chairperson has given me ample time, so I'll take my time and proceed. So then I can extend my, on behalf of the organizing committee, we extend our thanks for all the senior faculty members, alumni, residents, the pharma people, everybody for making this first day a grand success. And we hope to see you tomorrow in the morning at 8 o'clock for the next day. So this is just our experiences on how to overcome the sternal hurdle or the sternum when we actually need to expose the upper thoracic spine, especially for tumors and degenerative pathologies which will provide only a limited access. So start with a disclaimer that there is more than one way to skin a cat, and the approach and method that I feel is what I have given here and I have gone through, and the different surgeons may be giving different approaches which will be correct. And I don't claim that this is the only approach for treating these tumors or lesions. Credits to the thoracic surgery department and the neurosurgery anesthesia team, neuro anesthesia team, without which this would have not been done. So T1 to T4 was a no man's land in the earlier part of the spine surgical era, and this is because of the various peculiarities of the thoracic spine, where the upper thoracic spine, where the lordotic cervical spine meets the kyphotic thoracic spine, and it is a junction between the rigid and the mobile cervical spine with a rigid thoracic spine, and the spinal cord having less diameter there, and compared to the other areas of the spine where the diameter of the spinal cord will be, the cord occupancy will be less. And added to that, you have a unique set of structures anterior to the upper thoracic spine, which makes our life much difficult, including the thoracic inlet, which is narrowest at the upper thoracic spine, the sternum, which sits right in front of that, the great vessels, the brachiocephalic trunk, the aortic arch, and all sitting just right in front of the anterior ventral aspect of the upper thoracic spine. Plus, you have the musculature, the ribs, the brachial plexus, which comes laterally, and you have the shoulder joint, which obscures your fluoroscopy, the shoulder joint which obscures your anatomy, and the scapula with the paraspinal, the tough paraspinal muscles, which prevents you from entering into the ventral aspect of the spine from the posterior aspect to do a very good job of a corpectomy or a fixation. So with that background, let us go to what will be my aim. I am attempting to answer these 4 questions in the upper thoracic spine. When is a ventral access required? Why you choose a transmanubrial approach? And what are the challenges involved? And how can this be done safely? Or how we have done a few cases. So all these cases had the assistance of a thoracic surgeon, and because we are at the initial stage. So classically, when to do a manubriotomy, the answer is the cervicothoracic angle or the intervertebral disc line. So this is the main indication for doing a manubriotomy. If this lesion comes below the at or below the cervicothoracic angle in an MRI, or below the intervertebral disc line. So this intervertebral disc line is drawn by a line parallel to the disc space, which passes just above the manubrium. And the cervicothoracic angle is from the C7T1 disc space to the upper part of sternum, and the angle from there to the parallel line, parallel line. So the lower line is a parallel line from the superior portion of the manubrium, and the upper line is a line from the superior portion of the aspect of the sternum to the of the manubrium to the C7T1 disc space anteriorly. So if it comes in the angle, then plus minus, you can maybe get away with a lower anterior cervical approach. But if it comes below this lower line, definitely you will have to go in for a manubriotomy. So this is a classically described indication for a manubriotomy. And for us, in our case, we have gone through these cases manubriotomy only after we failed to attain the necessary exposure after a lower anterior cervical approach, as we had kept all these cases on the manubriotomy on standby. So in addition to that, what literature doesn't tell so fluently is the other indications when you do a manubriotomy. So the axial location of the lesion is yet another indication. So this is the ventral thoracic spine, and a T1 to T4 laminectomy hardly exposes these areas because of the constraints which I have told. And if you go to a little bit more extent, you can do a transpedicular approach, and you can maybe reach the ventral thoracic spine, but you don't have the freedom of the lower dorsal spine for doing a costotransversectomy or for going for a lateral extracavitary approach to put an implant from the posterior in the upper thoracic spine because of the unique anatomic constraints which I have mentioned before. So definitely you can reach the ventral spine, but how far and how clearly you can put an instrument or a cage into that and take out the entire lesion is maybe, I am not very confident in doing that in certain cases. So because of this reason. And third point is a high brachiocephalic trunk. So these have been mentioned sparsely in literature. The problem with the upper thoracic spine is that the brachiocephalic trunk crosses from the right to the left side, brachiocephalic vein. So this can be high riding. Normally it goes through the mid portion of the manubrium. It can be high and as high as the sternal angle, yes, as high as the above the manubrium. So we have had reports of where tracheostomy had caused injury to the brachiocephalic trunk. So this brachiocephalic vein and brachiocephalic artery can be cause serious problems when you have an awkward angulation without a manubriotomy and a lower anterior cervical approach with a steep angle to approach the upper thoracic spine. So this is another case where you will have to go for a manubriotomy, which can be seen in an MRI most commonly. And if you are doing a lesion, for a lesion and you do an angiogram, you can get an injection for that. Unfortunately, I don't have a picture of that. We had 2 cases like this. And next important point is kyphosis. Already there is a kyphosis for the thoracic spine, and it is a lordotic-kyphotic junction. So this is a normal spine. That yellow area is the depth to which the red arrow is the angle, line of sight of you when you don't do a manubriotomy, and then the yellow part is the part which you have to traverse when you don't do a manubriotomy. And see, when there is a mild kyphosis, that yellow part increases, so that you will be working at a depth without any control of a major neurovascular structure which may be lying just beneath the upper part of the sternum. So that is a problem with when you do go for a low anterior cervical approach for a lesion in the T2 or T3 without adequate preparation. The next is instrumentation. So the extent of removal, say for example the first case, there's a T1, T2 disc, will be easily accessible even if the sternum is a little high, because you need to just take out the disc. So unless the brachiocephalic trunk is that much high riding, this won't be an indication for a manubriotomy. Whereas the second case with a tumor, even if the manubrium, you see the manubrium seems low, and you draw all those lines and angles, probably in an obese patient with a little kyphosis and an abnormal brachiocephalic trunk, which was seen in this case, is a definite indication for manubriotomy, because we are likely to damage the brachiocephalic vein with potential catastrophic consequences if you want to instrument it properly and take the lesion entirely. Now, why choose a transsternal approach? So the approach to thoracic spine, everywhere from T1 to T12, you can use the posterior laminectomy, costotransversectomy, lateral extracavitary approach, all those can be used. But T1 to T4 is a unique area where this posterior approach has gross limitations, as I have already told. The other approaches are described posterolateral, there is a parascapular extrapleural approach. Again, very difficult with the scapula. Parascapular extrapleural approach is very difficult with the scapula and the tough muscles surrounding there. And transaxillary direct lateral, transaxillary or a transpleural transthoracic approach, again very difficult because of the mediastinal structures there. An anterolateral approach is not as difficult as this. You can resect the clavicle, you can even go above the clavicle, or you can go transclavicular, but that has serious problems of nerve injury, malunion, non-union, and separation of the sternomastoid muscles can lead to maybe respiratory problems also in the postoperative period. Anterior approaches, that is the supraclavicular, transmandibular and transsternal are the anterior approaches described, and they have also described full sternal splitting, manubrium, taking out the manubrium and without replacing it, or we replacing it with a prosthesis and things like that. But transmandibular and transsternal approaches are the direct anterior approaches. So when you consider the anterior approach to the ventral thoracic spine, these are the 3 approaches which you have: posterolateral, transthoracic and direct anterior. But the problem with the posterolateral approach is, as I told, the biomechanics of load transmission with adequate reconstruction of the body at the T1, T4 is very difficult with the posterolateral approach. And with the transthoracic, the muscles, scapula, vessels makes the access very difficult. So that leaves us the best approach as the direct anterior approach for the ventral upper thoracic spine. So this is what is the topic today. And briefly, the exposure, as I told you, is a very important challenge. So we have to take the neural structures, including the recurrent laryngeal nerve, the vagus, and the um, recurrent laryngeal and the phrenic nerve. These nerves can come into your way. The mediastinal structures and the vascular structures have to be taken care of. The fluoroscopy is very difficult, a little difficult because of the shoulder. Only AP views can be used to any meaning. And post-operative care also, not like a pure neurosurgical case, there will be problems with breathing, pneumonia, chest infections, mediastinitis, all those things can be, would not be very familiar to a neurosurgeon. So just briefly talking about the working angle. So this is the available working angle if you don't do a manubreotomy to reach there. Even you can go above, this red line can go above and you can reach up to T4 also. But then the problem is you have so many structures to negotiate in a blind area. And the optimal approach to put the optimal parallel space, the approach to the disc space will be, that is shown in green. That will be attained only if you take out that. Because for putting an implant, for putting, taking the entire lesion, working from above at a very awkward angle will not suffice in most of the cases. And this is the two windows which we can utilize. That is this is a brachiocephalic trunk. An above window. Once you do a manubreotomy, you can either use an above window above the above the subclavian, above the brachiocephalic trunk to reach the T1 and T2. And if it extends below T2, maybe T3, you should have to work even below the vessel to dig. And going into T4 anteriorly is very, very extremely difficult because of the aortic arch, and we have not had cases of T4 ventral approaches to T4 alone. We have limited it to T3, and it's extremely difficult to go to T4 anteriorly with the even with the splitting of sternum, because the aortic arch is right up there. And how to do? There are a few cases. We'll show you. I'll show you a few cases which we have done. This was a morbidly obese patient with, I think it was a diagnosis of plasmacytoma, and this was the CT angle was borderline, and intervertebral disc line was below. We started with a low anterior cervical approach, the backup for manubreotomy, but as you can see here, so the same position as we do for ACDF. And we extend to the second intercostal space on the right side. First we do a low anterior cervical approach, and then we expose the innominate, the common carotid, it's written wrong, common carotid and internal jugular vein. Then that is common carotid and internal jugular vein. And then we had to ligate the superior thyroid artery here. We had, even without that, we had that high riding artery, and we have looped it, and then we put it on the lowest disc space, which was at C6, C7. We were not able to go beyond C7 with that, so we decided to go on with a manubreotomy. And we usually use an expansile manubreotomy, and we do not cut the manubrium out. And then thymus was big, thymectomy was done to get the space, and then we looped you can see the central venous catheter inside the subclavian vein, which was looped. And then we got the prevertebral fascia. This was by an above approach, above innominate approach, and a 2-level corpectomy was done after excising the this thing. And you have to protect the subclavian, the innominate vein, because when you drill and all, if you touch the innominate vein, it's very flimsy and can lead to torrential bleeding. Even ligation of the innominate vein has also been described without much consequences. You can even ligate it. We have done in one case. Only thing is you should not give any IV line on the affected limb, that is on the right side, on the side of ligation. And this is the final picture. So this is yet another case. I don't know. This was a recurrent case operated recently last month, recurrent case, thrice operated schwannoma. Every time the histopathology has come as benign. Maybe first time was operated some 10 years back, then recurred after 5 years, now again recurrence. And there was a kyphosis and a scoliosis as well. This also we have planned, because of lack of time, I'm not playing the videos. So this also required manubreotomy, and the post-op MRI is not yet done. And this is yet another case of a degenerative case. We have actually two focal segmental OPLLs at two levels, C6, C7, and probably T1, T2. So what I thought was we'll preserve one vertebra in between to avoid very large length of the of the cage, long length of the cage, and then we had to, actually we had asked Jayon, and they have constructed a special patient, customized cage plate system for us, and where we could actually preserve one vertebra and then put the screws into that and then expand it above and below so that we could avoid a very long expandable cage. So this was what the intraoperative picture, and this is the final picture. And the patient, all these patients are relatively symptom-free after surgery. And this is yet another case of a plasmacytoma. Again, same manubreotomy, expansile manubreotomy. And then this is one aneurysmal bone cyst, young girl, double level T1, T2 corpectomy. And this is the post-op picture. These patients are all relatively symptom-free now. So manubreotomy is an essential tool, though rarely required. It's an essential tool in the armamentarium of spine surgeons. Besides the routine indications, high-riding brachiocephalic trunk and obesity bar kyphosis are relative indications. It is safe, effective, and provides direct ventral access, reinforces a strong anterior column, and avoids complications of extensive muscle damage and clavicular resection. Thank you.
It's a very, very good presentation, crisp, clear, and you did an exploration of uncharted areas.
Thank you.
So, what are the complications or difficulties you face regarding the thoracotomy in this case?
So the most important thing is this brachiocephalic trunk. You have to be very careful to guard it while you do this thing. See, our thoracic surgeon helps us for all cases.
Yeah,
then we have to be very careful for that. And you should not go back beyond the sternum. You go and curve it to the second intercostal space so that you can do an expansile manubreotomy alone. That sternum is left untouched. That is one thing. Second thing is you have to be very careful while drilling, because this subclavian, this innominate vein is very flimsy. So suppose it slips, means it's gone. It's very difficult. You can ligate it, actually you can ligate it and then do also if it's a problem. One case we have done like that. So I think those are the two problems. And the steep angle, you have to be always very clear. Even if you can see with a C-arm with great difficulty T1, T2 space, you will never be able to put a cage there. The only thing is the angle should be like this. You should get an angle, not like this. So those are the three things I found.
The paper is open for discussion. Any questions from the?
No, 0%, because we're not doing anything to the joint. This is right up like this, and then that slips back into place. Nothing happens to the sternum. No muscles, no ligaments are injured. No, nothing, no pain. That is the usefulness of this procedure. You're not separating any muscles here. You're not separating the clavicle. There are no ligament injury. Just splitting here, and you're going to a second intercostal space. So the movement is occurring there only, not in the sternoclavicular joint.
So you always use a posterior after you...
No. That is if the one case we are not done. See, if the posterior elements are involved, we fuse it. Tumor we fuse it. The degenerative condition we then fuse. Only the expandable cage finished. That peculiar cage we used, we never went back. For tumors, we go back because there is.
Because if you have posterior elements.
Yeah. Otherwise, also for tumors, if a lot of bone is removed, it's always better to reinforce. Either the tumor can grow inside, or he might require radiotherapy. So it's always better to fuse when there's a big tumor which you're taking it a mass.
Finally, we want to achieve uniformity between the C7 or T2 or whatever.
Yeah, that is a question.
So if it is expandable cage, you don't have enough space to put in bone grafts. So how do you manage that? Because I have faced that.
Yeah, that is there. That is a valid point, because we have now these cages with inside the holes through which we can put hydroxyapatite crystals. That's what we do now, and then we can actually jam it. So it goes after expansion. Also, you put this small hydroxyapatite, small crystals are there that you can put and jam it so that it expands and connects. But we have now maybe 4 years of follow-up for the first patient we have done. Still, he had not had any problems. Fusion. Not fuses completely. You can see some interconnection inside the cage. Not externally, you don't see anything. But the patient is comfortable.
If no more questions, we can wind up the session.
Thank you.
Thank you, sir. Now I request chairpersons to give the token of appreciation to our speakers. First, I call Dr. Ramesh Chandra Vimula, sir. to the stage. Next, I request Dr. Praveen Salunkhe, sir. Next, I request Dr. Tinu Ravi Abraham, sir. Next, I request Dr. Ganesh Divakar, sir. To felicitate the chairpersons, I request Dr. Biju Badran, sir, HOD, Medical College, Trivandrum, and Dr. Raj S. Chandran, sir, Professor, Medical College, Trivandrum, to the stage. So we'll pass our academic journey for today and we make our way to the dinner venue. Thank you. Hope we have